Welcoming everyone. I am Lauren Gueits, your host of this evening's AHS Masterclass titled Untangling Pediatric Tongue Ties, Indications Research, featuring Dr. Richard Baxter, Dr. Larry Kotlow, Dr. Scott Siegel, along with our special guest panelists, Dr. Kevin Boyd, Dr. Brett Christensen will be joining us, Dr. Milton Gavalis, and Brittany Sierra Murphy, and Peter Vitruck will be joining us as well. We are so thrilled to offer this event with free CE and recordings as part of our Airway Health Solutions Airway Health Movement. And we want to have special thanks to Light Scalpel for generously sponsoring tonight's masterclass to help make this happen. We have over 1,100 registrants tonight, so we're really thrilled with the with our record-breaking attendance tonight. We should probably have about 500. But on behalf of myself and the panel, we want to extend a warm welcome to our attendees. And let's get to know our audience a little bit better. I always like to do a poll and see who's with us tonight. So I'm going to go ahead and launch that. And let's see if you can just tell us your profession. That would be wonderful. And I am going to give that a minute while everyone logs on, and I just need to find one piece of paper with Dr. Baxter's bio. There we go. Okay, we have 70% participation. Let's see what we have here. Give a couple of seconds. People are still logging on. Wow, we're up to 358 already, so welcome everybody. So a lot of dental, a lot of multidisciplinary people with us. So welcome everybody. We're thrilled to have you here. And the format of this class is we're going to have basically 3 presentations from Dr. Baxter, Dr. Kotlow, and Dr. Siegel. They'll all be presenting for about a half an hour, and then we're going to have a panel discussion and answer some of your questions if time allows. And we will also have some updates. We will have a raffle at the end for Airway Health Solutions to win a free virtual ticket. So we're excited for that. But I do have to do some housekeeping items just for legal issues to protect our speakers and ourselves. A few disclaimers. The views presented are the opinions of our speakers and are not necessarily affiliated with Lauren Gueits and Associates and Airway Health Solutions. The following webinar is provided for educational and informational purposes only and does not constitute providing medical advice or professional services. The information provided should not be used for diagnosing or treating a health problem or disease, and those seeking personal medical advice should consult with a licensed physician or dentist. Always seek the advice of your doctor or other qualified health providers regarding a medical or dental condition. The other thing is just to receive your CE certificate, you must be in attendance for the entire program. Zoom software tracks attendance, so we don't not need to give you a code or a survey at the end of our presentation. That's when we'll have the live raffle, and the winner must be present to win. So we're going to kick off with Dr. Richard Baxter. Welcome. And then we'll be followed by Dr. Larry Kotlow and Dr. Scott Siegel. So I'm going to go ahead and do the introductions right before the presentation. So Dr. Baxter, why don't you go ahead and start sharing your screen and I will read your bio. Okay, so great. Dr. Richard Baxter is a board certified pediatric dentist, internationally recognized speaker on tongue ties, instructor of the online course Tongue Tied Academy, and author of the best-selling book Tongue Tied: How a Tiny String Under the Tongue Impacts Nursing, Speech, Feeding, and More. He lives in Birmingham, Alabama with his wife, Tara, and their 3 girls, Hannah, Noelle, and Molly. He serves as a faith trainer at the church at Brook Hills and participates in global missions projects around the world. Thank you so much for sharing your expertise and time with us, and take it away.
Yeah, thank you so much for having me, Lauren. It's an honor and a privilege to speak to you guys tonight. I will try to, as Larry said, try to get this into 30 minutes. So here we go. A few disclosures. I'm the owner of the Alabama Tongue Tie Center in Birmingham, Alabama. I did write the book Tongue Tied with a team of specialists, have an advanced live patient course at our office, and an online course, Tongue Tied Academy. The book and both course, all the royalties, all the course fees are donated 100% to charity. I don't have any interest in any dental or laser companies if I mention anything tonight. So we have a few translations of the book. So if you speak another language and you're on here, happy to have you check those out. We have a few more in the works. We have Portuguese, Korean, German, Zungenband, That's funny. And then Danish, I did a Danish webinar at lunchtime today. It's a stramt tungeband. That's how you say it. But anyway, and then Italian. Here's Tongue Tied Academy. That was 25 hours. That was my COVID project. And here's the advanced live patient course. It's as hands-on as you can get without having a dental license in Alabama. So, and here's what we do with the money. So a lot of water projects, some health centers in the Himalayas, some human trafficking projects around the world. So, and here's my family. You might have heard them in the background earlier. They just left. So anyway, but there's Noelle right here and Hannah. And those are our twins. They're almost 9. And then here's Molly. Molly's almost 5. Sorry, the girls are 9, almost 10. Molly is almost 5. She'll be 5 in a couple weeks. And so they're so big now. They keep getting bigger. And that's my why. That's why I do this and how I got into the field in the first place. Greg Notstein released the girls back in Ohio, and the rest is history. And a lactation consultant told me all about it. So here's kind of the roadmap for where we're going. But does anyone know who this is? This is the struggle bus. Moms do not want to have their baby or their child lasered. No one does, just like I don't want to get a root canal, right? I don't want to go see the endodontist. But if my face is throbbing, I will definitely be calling the endodontist and be breaking down their door. So they come see us on the struggle bus. And there's a few things we have to do to get to thriving, which is our goal, right? So you have to get a proper history. If you don't get the full history, you're not going to get the whole story. You're not going to get where you want to go. The goal is to stay on the yellow brick road. Right? You need to get a full assessment. A proper assessment will lead to the right diagnosis. Otherwise, you'll go off track. If you don't treat it right, it won't work. Right? If you cut it halfway, it's not going to work. If you do all that right, but you skip the aftercare, the follow-up, it also will not work. You really need all 6 of these steps in order to get to thriving for the family. Okay? So a few paradigm shifts. Basically, what's the difference here? Why does this work? And like what Scott and Larry are doing work, and then what another provider that may not have like looked into the tongue tie stuff, they just cut it with scissors, and then it doesn't work for them, right? Like what's giving tongue ties a bad name? Basically, this is kind of what I would do if I had like the old paradigm is what I would do if I had like a toothache, like I did earlier today. Had a patient come in and he's say, okay, what's going on? Where does it hurt? When does it hurt? And then we got them numb, got the tooth out, call us if you need us. That's it. Works great for a toothache, does not work so well for a tongue tie procedure. And so the problem is, I won't single anyone out here, but a typical provider that does these and thinks they might be doing them well, but they don't. They'll just do like, hey, mom, what's going on today? I'm having trouble nursing. Let me take a look. They won't put on gloves. They'll just use a tongue depressor. They might do a snipper clip, minimal, like 1 week, or just no stretches at all. Call us if you need anything, and it's the surgeon, maybe lactation, maybe a speech therapist. You might get some results, but they'll probably be minimal, right? It might work, it might not. Excuse me. So the new paradigm, what we're doing here, right, it's a little bit different. We're going to get a comprehensive history, like a full history from the parent, a full exam. I'm going to show you these things, a full release of restricted tissue, stretches 3 times a day for 4 weeks. The numbers vary, but in general, if you look at like studies on taking pills, for example, the more times you ask someone to take a pill, the lower your compliance. So we found that 3 times a day, morning, noon, and night, for about 4 weeks works for most people, and they're able to do it. Follow-up mandated. What does that mean? They might be 4 hours away. Well, it's either virtual, so sending pictures, or in person. Our preference is in person. And then we always use a team approach to care. So with lactation, with the chiropractor, the PT, osteopath, the speech therapist, myofunctional therapist, whoever. If you do all those things, you add it up, you will likely get impressive results. A few pearls. We always, again, worked with a team approach to care. All proper diagnoses start with a proper history. So mixed diagnosis comes from either not listening or not examining fully, right? This is the same steps, just in a little bit different order. We listen to mom's story without interrupting, empathize with her, look over all the symptoms systematically, one by one. We take notes, examine properly with gloves and tools. You do have to put gloves on, can't check them in the car seat. And you really need a mouth prop if you're going to check toddlers with teeth. This one's key right here. Symptoms and function are more important than the appearance, right? So if you just look at it, you cannot tell if it's a tongue tie in a lot of cases. A lot of these kids that come see us on a hygiene check, I probably won't even ask about their tongue because it's not obvious, right? And a lot of the babies with horrendous nursing pain for mom, a lot of those babies have a less obvious posterior tongue tie. So we take pictures of everything. This is to protect you and also for the parents when they come back. So you didn't get it all. Well, so here's the picture I did. We discuss the findings with the parents and then make a plan. That might be to release today or another day, but it's always up to the parents, whatever they want to do, right? Informed consent, all the risks, benefits, I think Scott's going to go over those. And so if it is indicated, you release fully and precisely, or if you're on here, your therapist, I saw a lot of therapists on here, refer to a knowledgeable provider who does this often. High quality stretches are critical, or else it'll grow back together. If you get your ear pierced but don't wear the earring, it's going to stick back together. And then I think showing that to the parents, having them do it as well helps as well. And then follow up at 1 week minimum, and then more often as needed. So this one is originally from Dr. Kotlow, so standing on the shoulders of giants here, obviously. I've adapted it just slightly, added a few things. But anyway, in general, the things on the left here are tongue issues, or like the motor of the mouth. So latching problems, gagging, choking, coughing, biting, hiccuping. In utero, hiccup seems to be one of the earliest signs of a tongue tie, interestingly enough. It affects the swallow in utero. On the right are more seal issues. You could say lip tie or buccal tie issues. So like the clicking, smacking, aerophagia, as Scott wrote about in 2016, reflux, gassiness, spitting up, colic, all these horrendous things that are common but are not normal or not optimal, right? It's just because it's common, like snoring doesn't mean it's normal, or teeth grinding, it's not normal, okay? On the bottom, these are all mom's issues. So again, often if you see like a horrendous pain when nursing, really bad pain, 7+ pain, often they're less obvious tongue ties. They'll often have feelings of hopelessness or depression. We actually check all the moms with the EPDS-10 and check on them also here, because sometimes they're not breastfeeding, so they'll just fill out the top part. So I wanted to move it up here. So anywho, the key is, what are we looking at here, right? The babies, this is what the traditional medical model, medicine 2.0 does. So if they have, a colic, okay, here's some gripe water, they're gassy, here's some gas drops, they're spitting up, here's some Pepsid, that's not working, here's some Nexium, it hurts, here's nipple shield, it really hurts and I can't do this anymore, I lost my supply, just do some formula, right? We're treating the fruit and giving them a family pack of Band-Aids instead of looking at the root, okay? The root cause, which may or may not be a tongue tie. It could also be like a chiropractic or like tension, like they're in sympathetic, they're fight or flight. It could also be other things as well. Prematurity, Down syndrome, we had all those this week. And so look at all the things, but in many cases, it is a tongue or lip tie. So for kids, we wanted a similar form. On one page, we see the majority of symptoms, about 50 items. So we want to know what history they had as a baby. This is like 13 months and up. We'll use this form, right? So what speech issues they have, feeding issues, sleeping issues. Those are the big three. And then we have these kind of other ones down here. So these are kind of more adult issues, but can also affect kids, like headaches, migraines, TMJ issues, neck tension, hyperactivity because they're not sleeping well. And then the lip tie issues are down here. So patients will come in and they'll check off a bunch of these and then check off a bunch of other ones and say, oh, doc, my baby only has my child only has a lip tie. And so if they check off all those, there's very likely something else going on with the tongue. Okay, so the lip tie is just down here in this corner. The rest of them are more tongue issues. So I don't have time to go over all those. Go over and there's a YouTube lecture. It's about an hour you can watch, or Tongue Tied Academy, obviously. Problem is, it doesn't get any better. So as they get older, the symptoms can disappear. But they can also come back and they can change over time. So here's our adult assessment for teens and adults. But speech issues, they get embarrassed, trouble singing. We've done a lot of opera singers that have like to the tip tongue ties. Sleeping issues, they need a CPAP, they're snoring. If you guys are airway dentists on here, you'll see these issues. And often a tongue tie at birth is what precipitated a lot of this. They weren't able to nurse. They had maybe poor food choices because they weren't sleeping well at night. Their leptin, ghrelin levels are off. They got overweight, flabby tissue, excess fat in the tongue, it flops back in the airway, sleep apnea, UARS, SDB, the whole thing. Anyway, so stress or anxiety, like all kinds of stuff. Even constipation, we often see improve. Teeth extracted, jaw surgery in the past, they have breathing issues, mouth breathing, all kinds of things. So how do you check? Well, coming from behind is the best way. So then you and the parent can both see. We check just like that. This is a family. She's from pediatric dentist from Germany. And she came and she didn't realize that her son had a like almost to the tip tongue tie, right? It was pretty impressive. And we released it. And he was already talking better, sleeping better, and eating better while they're still in the States. So here's a baby. I know kind of we'll focus on pediatric here, but here's the baby. So it's going to show the assessment. So lift the lip up all the way. This is blanching. The baby doesn't like that. We'll check for the cheek ties or buccal ties. Up there, you can see it right there in the corner. It's like right where the canine, like first molar would be. So this one's pretty tight. So that'd be in the gingiva. That'd be like a class 2. We'll talk about that in a second. We have a new classification system as of October. And then here's the tongue. So if you look on the tongue, that's pretty tight. So it's like probably 50%. I use Larry's, Dr. Kotlow's classification system. Some people use the Carrillo's classification system that Dr. Siegel worked with, Betty Carrillo's. They're like the exact opposite of one another. So like a 1 is a 4 is a 1. So sometimes I'll just use percentages for parents or if I'm talking to a provider because they might use that system. Here's just another view lifting up. Notice the blanching on the baby coming from behind again. Always check for the cheeks. The tongue is primary. The maxillary lip tie, upper lip tie is secondary. The cheeks are tertiary. They're not as important. If you had to pick one area to the release, almost always the answer is the tongue. Lip would be secondary. Cheeks can help. We just don't know to what extent yet. We have an article. It was just a survey, but it's 466 providers. I'll talk about that in a little bit too. But that's a to the tip tongue tie. That's way too tight. Right. Here's a release on that baby. So this is the CO2 laser. I won't mention any names, but this is the CO2 laser. It just hovers right above, heats the tissue to 100 degrees Celsius, and it vaporizes the tissue. It's not burning it. And so this is the quickest. It's about 15 seconds, most minimally invasive way to do it. People think that a laser is like, like a lightsaber. That'd be super cool if it was, but it's not like that. And that would not be safe, obviously. But if the baby moves, you put your foot off the pedal and it's no longer emitting any photons and there's no problem, right? If you have scissors, they're always sharp, right? So it's so much easier. Look at the dissection. You can just go in there. There's minimal to no bleeding. You can lift up and you can see, okay, there's muscle, there's fascia, there's the nerve, stay away from that. There's the deep lingual vein, stay away from that. And so you can really pick out and just draw on it almost. It's easier than scissors. I used some scissors in Nepal when I was on a mission trip there. You can do it with scissors. You can do it with other methods, but like, I was so glad to be home and it makes it so much easier. So here's just a quick case. This is a 4-day-old male. A couple things to notice. Often people come in, they have lots of check marks. The longer you wait, the more check marks you get typically. This one, terrible pain. So we're thinking, okay, it might be closer, like further back, like a less obvious tongue tie. Sure enough, when you look in there, pretty good lip tie there. It's blanching, and they have a lot of seal issues, right? And then the tongue, they have some tongue issues as well. And so the tongue lifts maybe halfway, but it could lift better, right? For this individual child, the thought is that it's likely too tight. Again, Scott's going to talk about risk versus benefit, but we're looking at you're trying to help the babies thrive and not just survive. So if they're gaining weight, that's good. So this one was gaining weight, but we want to look at all the issues affecting the family. We want to make sure we do the best for that individual family and then look at the risk versus benefits. If this is my child, what would I do? And here they are a week later. So lip doesn't curl under, deeper latch, less popping off on the nipple, getting more milk out, much less pain. Was a 7, now is a 1. Feeling more confident, better emotional state. And that's been backed up with studies. Gahari's study talked about that. Amazing, worth the drive 1,000 times. They had to drive a long way. A lot of our patients have to drive 3 or 4 hours or further. But anyway, so it can help with all kinds of things. And here's the result. Here's the treatment on that baby. So again, it's very similar, slow hand speed, coming right down on it because it's a laser, so it shoots out, so you can't come from this side. But anyway, this masterclass tonight is not enough to just start doing tongue tie releases. Just putting a disclaimer out there. You really want to get more education than that, just watching these videos and start doing it. So anywho. Here's the tongue. Lift up lots of tension. And then you want to get right between the salivary ducts and the tongue body. There you go. And just releases it. And it's like 5 seconds or so. That's all it is. When the Daily Mail picked up the New York Times article and said, U.S. doctors are wrongly slicing off bits of babies' tongues, leaving them with lifelong deformities, that is a huge exaggeration and not even close to what's happening. Okay. Because there are 4 classifications for lip ties, just want you to recognize it's a spectrum of lip restriction. These ones may not be causing any issues. These ones are blanching, they're tighter. This is the tightest one, like the shortest I've ever seen. Could not flip out at all. Sometimes it's notching the bone. Often there's blanching. So there's just some things to look out for. There's often a dimple on the upper lip right here. So Again, going quick because we don't have much time. I want to respect everyone's time. To the tip, very thick. Sometimes it's thin. And what happens is they'll just snip it, right? The pediatrician or ENT or someone will just snip it, a dentist possibly. And this is what you're left with, right? These two right here, these ones were snipped previously, okay? And you see they're still restricted. They didn't get that back for follow-up. They didn't realize there was still tissue left over. Or if they did do it properly, they didn't do any stretches afterward and it stuck back even tighter possibly. Okay, so you see those, like the thick white tissue, you can tell those have been done previously. But even these ones down here, even this one right here affected that individual baby, right? Say, how do I know? Well, they got better afterward. We saw improvement, and not just like 3 weeks later. It was like the next day we saw improvement. Okay, it's not coincidence. It's like if you put a turkey in the oven and it turns brown, you say, oh, it's just coincidence. Like, no, it's right. There's something there. We affected a change because we gave them more tongue mobility. So this just to show that sometimes you look in there and it's not obvious, right? They have all the check marks on the form. You look in there, it's like, what gives? There's nothing there. Lift up a little bit, see the fascia start to bunch together. Lift up with 2 fingers, you see, okay, now we can see it. And that's how you're going to release it. You're going to release it under tension like that. Here's another one. This is an example from a hygiene check. So I saw this patient, O and P were turning in, right? They were turning in, one's fused, but I saw there's a little something under there. And so I lifted up and sure enough, it's a little bit tight. Now, I don't know if that's a tongue tie or not, because it has to be causing a functional problem to be considered a tie, right? Look at this. Okay, now it's tighter. So I asked mom, hey, mom, any speech or eating or sleeping issues for Johnny? And they said, no, he's good. I said, okay, great. Just let us know if you have any concerns in the future. So we do not treat that because there's no problem, right? We don't just want to laser everyone. Then that'll give everyone a bad name. So please do not do that. But it's a very powerful tool if they actually do have it and there's a problem. So this is from an article and from October. It's out. It's if you type in Baxter buccal tie, it'll pull it up. And so we have a classification system. So mucosal, basically, it's obviously up in the mucosa. The gingiva, it's somewhere in the gingiva right here. Alveolar comes down like this, like a flag. They're not as common. A lot of them are class 2. And so basically, there's a few different ways we can help to figure out if they need it or not. It's probably 1 in 10 tongue tie patients we do. We're not doing this all the time. Maybe once a day we'll do this. But it's blanching the tissue. It's turning white. It's uncomfortable to palpate. Has a clinical impact. So like a seal issue. This is what compensation patterns are there. Attachment site. That's the classification. And is it limiting the range of motion? We do not charge for buccal ties. Right? We're not trying to get rich off the procedure. Someone on IPEDO, it's like the Pediatric Dentist Facebook group said, like, I could do 2 crowns and like make way more money than doing a tongue tie and have way less problems. So anyway, so yeah, we don't charge for buccal ties. It's just included. And then minimal risk, and there's a possible benefit. Again, if you're going to pick one area, it's the tongue. 2 areas, it's the tongue and lip are the most important. The cheeks are tertiary. And often if we're doing the right side, we're going to do the left so we don't have an asymmetry. Okay, so child assessment. Again, symptoms and function are more important than the appearance. So this one had perfect speech, right? This one over here was nonverbal. Now he also had autism, but notice the floor of his mouth is lifting up too. We released that. He came back talking the next week, had several words, was eating better, sleeping better, less mouth breathing, less snoring. Made a huge difference for their child. Okay, so all different appearances. Lip tie, same way. This one has like a dog leg. You know, they can have like caries starting there, a large diastema, blanching the tissue. It's really difficult to brush their teeth. So those are kind of reasons we release it in children, and it's all on the form. So you think, well, I'm not going to release these. I just want to see like maybe in my hygiene, or if you're a pediatrician on here, like a well child visit, or, you know, you're a therapist, like how can you quickly screen these patients? We want something that's easy because otherwise no one's going to use it, like the Hazelbaker, like no one's going to use that really in private practice. That combines the symptom, the function the parent desires. So basically this is just to have a conversation with the parents. It should be useful, or else what's the point? And it should reliably predict related issues. And of course, we want to prevent treating if there's no issues. We never want to overtreat. We also don't want to undertreat. We try to get right on. So the first step, don't worry about this right now, but is this the tongue range of motion ratio? How high can they lift their tongue? Okay, so if they can lift it less than 25%, that's a grade 4. Less than 50% is a grade 3. 50 to 80% is a grade 2. And then grade 1 is above 80%. Okay, but you have to check for the floor of the mouth lifting up. So if you hold a glove finger down here, you can check their true mobility, all right, and control for the compensation. This was published in 2021, the tongue restriction questionnaire. You can Google it. Basically, it's the greatest hits of our child assessment form. And you can just print these out in hygiene. The hygienist can have the parent fill this out. When you come to the check, they can see, okay, they have a speech delay, they're spitting out food, they're snoring, and they're mouth breathing. How significant did it impact quality of life? Significantly. How tight is the tongue? Well, it's only a grade 2. It's not that bad. And then this doesn't say, yes, do a tongue tie or not. That's not what this is. It says there was a referral recommended. Well, if these were the check marks, I'd say yes, because they're significantly impacting quality of life. Snoring is a red flag. Speech delay is a red flag. Even though it's a less obvious tongue tie, it's probably worth getting checked out. So that's all this form helps to do. You can download this and then our other forms, and then all the research articles are all in like a zip file. I will send it to you on our website right there if you'd like to. So anyway, the QR code will be at the end too. So some people say, well, how do you choose who to release then? And so I made a graph to try to make it as easy as possible. If it's obvious to the tip and they have lots of symptoms, that's a slam dunk, right? Most of the time you'll get something. Now, I don't know if we'll get speech better and not eating better, or sleeping better but not speech better. It's kind of random or variable. Conversely, if it's obvious like to the tip and then there's some symptoms, a few symptoms, that's also worth doing. If it's minimal though, this is where a lot of people miss it. If it's minimal appearance, but they have lots of symptoms, that's also ripe, like low-hanging fruit. Okay, it's not obvious and they have lots of symptoms. Those kids can also benefit. And those are the ones that slip under the radar. So certainly I can't check every kid on hygiene and like tell them all they have tongue ties. No one will come to our dental office because they think, like, oh, we're just telling everyone they have tongue ties. So you have to be like discreet about it. But if you see something, you ask, hey mom, any speech or eating or sleeping issues, right? And the only time you're really waiting is if it's minimal and there's just a few symptoms, just wait on it, right? We had a study in 2020. It's a prospective cohort study, so that's level 2 evidence, significantly better speech, eating, and sleeping at 1 week and 1 month follow-up visits. First article to show improvements in speech delay, picky eating, slow eating, choking, snoring, and restless sleep. And so this one was very helpful. There's 37 patients in it. You can download the article, or it's in the forms if you get the forms. But this one's helpful to show to skeptical providers, basically. So real quick, we'll finish up with 5 keys for a proper release. Basically, anesthesia, make sure the patient is comfortable, cause the least amount of pain. Again, your tool can determine this a lot. If you're using cautery or diode laser, it's going to be hotter and it's going to go deeper and it's going to hurt more during and after the procedure. You want controlled, efficient cutting. We use strong topical for kids, like above 12 months. We use a strong, like compounded topical. Around age 5-ish, we'll consider adding some injected topical right into the frenum. With 2% lido with epi. We'll use a dab of viscous lidocaine, 2% viscous lidocaine for under 12 months. That's debatable. Some people don't use that. I think it's helpful, but that's debatable. Precision. This is not debatable. Do not cut into the body of the tongue, right? Do not cut down here. One pediatrician in our area started cutting like the base of the Eiffel Tower recently. So had to tell the OB to tell his friend, the pediatrician, to stop doing that, please. Because it came in and it was still bleeding 3 weeks later, is causing problems. This one was clipped, I don't know when, they said as a baby, but I don't know what they did. So obviously they didn't get it. So this is the afterward. This one was clipped right here and right here. So you have to do it right. You can't cut in the salivary ducts. That's a bad idea. You really want to go right here, okay? All these ones were previously clipped. We see it every day. I'm sure Scott and Larry see it every day. Again, they didn't get them back for a follow-up, or else they would have seen the tongue is still restricted. Okay, once you get pictures of it, a picture's worth 1,000 words. This one, he was 36 years old. It was clipped as a baby. It does not stretch out over time. The upper lip tie, right, has a relative shortening over time, right? Around like a 1-year-old, 3 years old, 5 years old, you'll see that upper lip tie shorten a little bit. So I think because 94% of babies have it, and then later on, it's like half the kids or even less, 20%. And so that shortens relatively. So I think that pediatricians think, okay, the tongue is going to also stretch out, but it doesn't. It will stay the same from the day you're born to the day you die, unless there's an intervention. This one was cut into the salivary ducts. Huge lip tie was left untreated. Here's again another video. It's the same as the earlier one. It's similar. I'll show it. So here's a lip tie again. Lots of tension. We're lifting up as tight as we can. A tight tip to tissue distance for the focal length of this CO2 laser. and it just disappears, right? It vaporizes the tissue. It almost like erases it. Typically minimal to no bleeding. You can see everything. This is not sped up or slowed down. This is real time. And it just disappears. So again, we're not like frying the babies. We're not burning the babies. We're not disfiguring the babies. That's not at all what's happening. Not even close. There's a posterior, not obvious tongue tie. It's 3 seconds, right in the middle, a horizontal slice, and then the fascia just kind of melts. It just disappears. Right, there it is. It's gone. Okay, and that's the genioglossus that's left untouched underneath. All right, same thing. So you do have to feel for the fascia because sometimes it can be tighter. Here again, the lip, just slow movements. The faster you move, the slower it cuts. All right, here's another lip. And then you'll see the tongue is pretty tight on this one. So there's a little bit of bleeding. Sometimes there's a little bit. If you hit the periosteum with a couple pulses, you get a little bit of bleeding. All right, so almost done. There we go, perfect. Now the lip flips up easily. And now when the baby's nursing, they can get a good flange at the breast or the bottle. You have lots of bottle feeding babies too. Can make a difference for bottle feeding. The Harry study in 2022 showed that. So this one's pretty tight. So we're gonna release it right in the middle. So make sure you get a good clean shot before you start lacing. And then they're side to side, nice and easy. We're gonna feel for it. Might be a little bit more. And then we're good. Okay, you have to feel for the fascia. All right. So here's how do we do it on a 2-year-old? Well, we have the parents back, holding hands, laser safety glasses on everyone. It's no worse. I had to do a filling today on I was like a 1-year-old. I had to do 2 fillings on a 1-year-old. That is way harder than doing a lip or tongue tie release. Okay, so much harder. It's not even close. But as pediatric dentists, we have to do that all the time, right? Filling on 1-year-old, 3-year-old, that's uncooperative. And so this is how we do it on a 2 or 3-year-old. I did get bit there, so that's why I keep this video in, even though it's an old one, because always use a tooth chair or a molt mouth prop. Okay, so here's a molt mouth prop, so it's holding the mouth open. This one's pretty tight. Again, we're going to release right in the middle horizontally. We're not trying to take muscle, just getting all the fascia or connective tissue. It's like the stuff you pull off a chicken. There we go. A little bit more, but so you can just dissect out. You can see it all. There's a little bit tighter over here on a symmetrical diamond. You don't want them to have more mobility on one side than the other. And there's the deep lingual vein, so we'll stop. See how clearly you can see that though? You can't do that with scissors. So you need to make one cut, you can't see anymore. All that to say, it can be done incorrectly with a laser. So this is the diode laser, which is a hot tip. They use silver nitrate to stop the bleeding. Significant post-op pain, nursing strike, posted on Facebook for all to see. New York Times is going to call them. You know, that's the kind of thing, right? That's who they pick out. So just kidding. But seriously, it gives everyone a bad name. So please do not do it. If you're going to do it properly, get the training to do it right. Aftercare, it heals rapidly by secondary intention. So we make a horizontal cut. We're trying to trick it to heal open and then to close in from the sides, okay? They can nurse right away. It can look like infection or pus, but it's not. They'll often drool more. We dose the Tylenol. This is key too. If you do releases and want a pearl, dose it 1/4 ml per pound. So 6 pounds is 1.25, okay? 7 pounds is 1.5. 8 pounds, 1.75, 9 pounds, 2 mLs, like that, okay? Some improvement, though, often the same day, but it takes about 3 weeks for them to relearn. Call every patient at night to check on them, make sure they're doing okay. We show the parents afterward, have them put on gloves and do them too. Recommend 4 weeks, 3 times per day, but quality over quantity. Actual stretching time is like 5 to 10 seconds. Show them before they leave. You got to push down on the floor with the mouth and then back up, okay? Let me show you a video on how to do it. This is on our YouTube if you want to show a patient. Hi, this is Dr. Baxter. We're going to go over tongue tie stretching for infants. Once you do these stretches 3 times a day for 4 weeks, we'll start with the upper lip, lift up all the way, and flange all the way out, and massage right on the site. That's really important. Get all the way up in the vestibule about 3 times. Okay, the tongue, hold the lower gum pad with your non-dominant thumb. Push down and stroke backward. Pretty firm right on the diamond. Make sure you get all the way in there. Quick. Your baby had cheek tie release. Cheek tie. Go up on the cheek in the vestibule. On both sides, just about 3 times. The same thing, just kind of separating the tissue out, making sure it looks good. One more time. Here it is again. So lift the lip up all the way. It's real quick, not taking minutes and minutes. Just get in there and get out. Push right on it, pretty firm pressure. The babies do not like it. If there's a better way, we would do that, trust me. Hold the gum pad with your thumb, one index finger, and watch out, see that slipped back. So push really good. Don't let the tongue slip back. About 3 times right on there so you see the whole diamond open up.
The deeper stretch is
Now,
key.
a deeper stretch, if you don't come back for a follow-up at 1 week, do this, or if symptoms come back at any point. So this is 3 weeks later. There's still a string there. It came back. So I'm going to push down right on the string, just like a normal stretch, but right in the middle. Notice it opened up some. Stroke it back a couple more times. You'll see it'll open up some more. There will be a little bit of bleeding whenever you do this, and then it opened back up, but now it restored the function of the tongue, and then symptoms should improve afterward. If you do have any questions, please contact us. So that's really helpful, the deeper stretch. I'll show that too, because if symptoms come back or if they didn't do stretches enough, no one wants to hurt their baby. No one wants to push on them. So almost always they do not use enough pressure. About 90% have lost some mobility and they need a gentle but effective deeper stretch. It's really a normal stretch. We just call it a deeper stretch so the parents don't feel bad. A lot of this is psychology, and it takes a lot of that to work with these moms and babies and kids. So for kids, like 12 months up and up, 2 times a day for 4 weeks, minimum once a day if they're like super uncooperative, have autism, and are like 10 years old. For best results, obviously work with a speech or myofunctional therapist. Just like for babies, we're going to work with a lactation consultant or a feeding therapist. Myofunctional exercises twice a day or as directed. Follow up with all patients. This is so key, especially if you're getting started. You want to follow up with all patients. In-person is our preference, but email is okay too. Check for symptom improvement, check for healing, do the stretch with the parent watching. Warn them there might be some bleeding. That's key. Otherwise, they'll say, oh, Dr. Baxter just ripped it back open. So you have to warn them. Be gentle, just go right on it. See right here, just slow back and forth, and you'll see it'll just stretch out. Sometimes it doesn't, and they say, great, Mom, A+. If it does stretch out, there's a little bit of bleeding. Okay, you get an A, right? Everyone gets an A for effort. Again, team approach, lactation, speech, PT, chiropractor. If the babies are really tight and tense, it's going to take them a lot longer to improve. And so ideally they have body work beforehand. So PT, chiropractic, osteopath, CST, something beforehand. Otherwise they'll be so tight, they cannot relearn. Like if you're running away from a bear, you shouldn't be studying. Okay, their body, they're in sympathetic, like attack mode. We need them in chill mode. Okay. And then what you can do with the follow-ups is you can change your surgical technique based on your findings. Here's the deeper stretch on a child. Notice that like T shape, it looks like a T. There's a horizontal line right there. So when it's pushed straight down, it just stretches back out. It's like taking a scab off your knee. It smarts right away, but then it's not awful afterward. But it can look bad. And obviously they cry. But anyway, so there's no improvement. Again, like what should you do? Perform the deeper stretch. Make sure they're seeing the lactation. Make sure they're seeing the chiropractor, other therapists. Again, the tight babies take longer to improve. Reassure, time, prayer. We pray with all our patients before we do the procedure. And then sometimes it takes 3 weeks for improvements. Sometimes it takes 7 days. Everyone wants a quick fix. This is to allow the therapy to progress quicker, especially for older kids. They have more bad habits, or older babies, more bad habits. It's going to take longer to see improvement. 3-day-old baby, probably improve fairly quickly. There's the team approach. Again, everyone's working together. We're not trying to do this in a silo. We're not trying to just laser babies and make money and not help. We all want the best for the patient and for the babies. So some takeaways is the last slide, but proper assessment, evaluation are critical. Ask them to lift the tongue. Like if you're on a hygiene check or if someone asks you on the street, do I have a tongue tie? Do not have them stick it out. That's the worst test. Have them lift up the tongue. Symptoms and function are more important than the appearance. Common does not mean normal or optimal. Screening should be conducted at hygiene visits, well child visits. The sooner it's addressed, the more team members, the better. They have to be assessed, diagnosed, treated, and followed up properly. If you skip any of those steps, it will not work as well. You will not have as good of outcomes, and it gives everyone a bad name, basically. They also can change over time. They can disappear and can come back later, and they can last a lifetime. And they place significant limitations on the patient and family's quality of life. You will survive with a tongue tie, almost always. You will survive with a tongue tie, but you may not thrive, or it could be better. So if you want to check out our website, download the forms. There's a copy of the book for free. tonguetieal.com is the website. If you want Tongue Tied Academy, we have a code for you guys. It's AHS, Airway Health Solutions. Or if you want the light, it's AHS Light. That's either $300 off the full course. It's 25 hours. That's for release providers to learn how to do it. 25 hours of ADA approved CE. Or the Tongue Tied Academy Light, it's $150 off. It's 13 hours. That's for therapists or people that are not going to do the procedure. So Whew, we'll have time for questions at the end, but I think I got close to 30 minutes.
You're right on time. I'm really impressed. 7:40 on
Okay.
the dot. So thank you so much. That's
Okay,
a
good.
wealth of information. And what's so great about this is that it is recorded. It will be available on YouTube, so everyone can refer back to this and your wonderful resources. Panelists, I'm going to ask you if you, while you're not presenting, and if you see questions that you can answer, especially Dr. Baxter during your presentation, there were some questions in the chat. Perhaps you could go ahead and let's chip some of those away. So
Yeah,
we can
yeah.
have
If you have some, I do. You want to tell me or? Let's
Yes,
see
so
here.
in the Q&A, you can stop sharing your screen, please, and then I will introduce
Q&A.
our perfect. Yeah, can you access the Q&A? Do you see it?
Yeah, I can see it now.
Perfect. Okay. So our on that whiteboard somehow.
No, not the whiteboard.
No, not the whiteboard. Let's stop. Dr. Kotlow, somehow we are on a whiteboard screen. This happened during our practice session. Maybe you stop share and try to restart your share. And meanwhile, I'm going to go ahead and read your bio, and hopefully we can figure that out. But if you can't get the whiteboard off, I think you may need to log back in. So
the whiteboard gone?
yes, it's gone. So try to share your screen again, and I will go ahead and read your bio. Dr. Lawrence Kotlow is a 1972 graduate of the State University of New York at Buffalo Dental School and completed his pediatric dental residency at the Children's Hospital in Cincinnati, Ohio in 1974. He became board certified in pediatric dentistry in 1980 and is a life member of the American Dental Association, a life fellow of the American Board of Pediatric Dentists, and a life member of the New York State Dental Association and Third District Dental Society of New York, member of the AAPMD, and has been a member of the Academy of Laser Dentistry since 2000. He has achieved mastership from the Academy of Laser Dentistry, and Dr. Kotlow is the author of more than 30 peer-reviewed articles, 2 textbooks, Atlas of Tots and SOS for Tots, which we recommend on a daily basis, about lasers, infant frenectomies, and breastfeeding. He has contributed to various chapters in 6 textbooks in laser dentistry. So it is my pleasure for him to share with us the next segment, which is the benefits of tongue tie revisions, a research review.
Okay, so hopefully you can see the slides, but it starts
You
out
can.
with our thoughts and how it affects our child's entire well-being. I'm not going to go through my CV. I'll go through my disclosure. I have worked with various laser companies over the years, made videos for them. Presently, I do work with Convergent Dental, and I haven't trained since COVID, but they do work with me with my course. Just advertising it, they have no effect on it. There's nothing in this lecture other than my own personal information and stuff that I've worked on that would have any relevancy to my content. I do want to give all these people credit because either through live meetings, private discussions, webinars, you may see some of your own information on here. I've tried to give you your credit when credit is due, but if you see it there and I haven't, I'm giving you all the credit right now. So all these people, I've been in practice 52 years and I've been doing laser surgery for over 25. So I have plenty of experience and I work with that. We want to focus on patient care. When infants and mothers present with these problems, it's a puzzle and we need to assemble the parts. There's a lot of different specialties and disciplines and maybe we overlap, but the landscape is changing and I'm going to step on some people's feet perhaps tonight. And if I do, I'm sorry, but it's fact, okay? I deal with this all day. I see between 10 to 15 patients a day from an hour old all the way up to 18 to release ties for a variety of reasons. So I wrote this article. The time has come for the pediatric dentistry and medicine to develop a new thought process. Rather than thinking outside the box, we need a new box. These are available on my website. So we're going to open up a new box today. The benefits, okay, we wear many hats. Talk about attachment theory, postpartum depression, successful breastfeeding, reflux, obstructive airway problems, and all the things with that, mother's supply. And each one of these could take me an hour to go through. So we're just kind of listing them. And it goes all the way up into adulthood. So ignoring these things. But we were our tots. We talk about postpartum depression, failure to bond with the mother. We talk about home cooking versus breast during manufacturers. We talk about air-induced reflux and the drugs that are used. Sleep apnea, all of these things have a lifetime of an effect. So when someone says we're cutting tongues and damaging babies, that bothers me because that shows they don't know what they're doing. Now, the New York Times article, which I'll mention briefly, that woman interviewed me for over an hour and wanted to get back to me. And I never knew when it was being published. And she did nothing for what my content and what I told her would be. So I'm going to have you listen to this one. And I want you to see the failure of the breastfeeding team. If I was to give you an exam, pick out all the specialties that blew it here.
I first heard about Dr. Kotlow in October 2017, when my nearly 3-year-old has significant speech delays. I was doing research on how I could help her improve her speech after being dismissed by my pediatrician, speech therapist, and occupational therapist that there was not a thing wrong with her. They claimed her speech was delayed because her 2 older sisters probably did all the talking for her. After learning about Dr. Kotlow and tongue ties, I went to our pediatrician and dentist and asked them to check her. Both said she was fine. After additional research, I determined she had a posterior tongue tie and made an appointment with Dr. Kotlow to confirm. Sure enough, she had a posterior tie. We had it revised in the office that day. On the way home, my daughter was moving her tongue around, and in 2 days, she was saying words she had never said before and was clearer. Her face looked more relaxed and her disposition changed. Prior to being revised, whenever my daughter had a pediatric appointment, I asked them how I would know if she had an underlying problem and her crankiness was just personality. After she was revised, she was a happier kid, and I think it was frustrating with nobody able to talk and now able to communicate. I visited my family out of town in August, prior to her revision, and again in December, after the revision. I purposely did not tell them anything about the tongue tie to see if they noticed a difference. Within 2 hours of arriving, I started getting comments about how my daughter was totally different kid since she saw them in the summer. They commented how much better she was talking and how much happier and personable she was. I know some of this could have been natural age development, but the night and day difference I saw prior to revision and a week later was confirmed by my family. My second success story is with my now 7-year-old, who was 5 years old at the time of the revision. She has sleep apnea, which I only figured out when I was doing research on my younger daughter's sleep delay. I kept coming across how tongue ties can cause sleep issues and signs of sleep apnea. The signs fit my 5-year-old to a T. Since my daughter was 1.5, I would mention to the pediatrician at her annual checkups about her odd sleeping behavior. I was told it was night terrors. Now learning 3.5 years later that this is actually sleep apnea. Seeing the success with the tongue ties revision of my 3-year-old had, I scheduled an appointment for my 5-year-old. One of the issues which was most embarrassing to my 5-year-old was nightly bedwetting. We tried all the tricks to stop her from wetting her bed and nothing worked. Within 1 week of the revision, my daughter stopped wetting her bed. In the first year, she might have wet her bed only 5 times. In the second year, 1 time. She now gets up during the night if she has to go to the bathroom. Her journey with sleep apnea still isn't over. Last year, her tonsils and adenoids were removed. These 2 successes led us to have our new baby revised. At 6 weeks, I noticed her exhibiting the same nursing behaviors as her older sisters. Their tongue ties, like the baby, went undiagnosed because their weight gain was good, because I have a strong letdown, so they did not have to suck for milk. I am being proactive, and I am thankful that my baby will avoid the speech and sleep apnea issues the older sisters experienced. Thank you, Dr. Kotlow.
So that shows you all the failures of the breastfeeding team. So we're going to talk about why we do tongues, why we do cheeks, why we do lips, okay? And what's all the fuss about it, and how we're changing lives. We change the family, we change our lives, because there's nothing we do that gives me more satisfaction than helping mothers and fathers and the babies. So let's take a look quickly. What are the adverse physical effects? There's 15 minimum, and there's adverse systemic effects, and there's another 16. I'm not going to read them to you. Go back and look at them, but These are all effects of a lingual and upper lip tie in conjunction with one another. And if we talk about sleep disordered breathing, we could add 30 more to it. But these are all areas. When I talk about wearing different hats, all of these things may be related to the tongue, which is connected to the spine through body fascia, and we just don't have enough time to go into all of that. Okay? Randomized control studies, they're a barrier to what we do because I think it's old school. And I'm going to tell you that, and you don't have to agree with me, but we have to worry about medically necessary care, anecdotal care, evidence-based, and more importantly with babies is scientific plausibility, which we'll discuss. Okay, medically necessary care, according to the American Academy of Pediatric Dentistry, is to prevent or eliminate, restore form and function, to correct dysfunction. This includes all healthcare services related to the oral and dental anomalies. It's not a disease, it's not an injury, it's a congenital or developmental abnormality, and we are doing therapeutic and preventive care. And I send this to every insurance company who says it's not medically necessary, and most of the time they have to back off. Failure to latch, poor suck, all have problems that can be related all the way into adulthood, and we'll touch those in a little bit. That's why when people lecture on TOTS, I get upset because we all have tethered oral tissues. We have to deal with the ones that are restrictive. So when someone says they're giving a course on TOTS and they don't say restrictive, I just don't feel they understand the whole concept. Ignoring obstructive airways impact children for a lifetime. Barriers we face, okay? There's a whole wall of things we have to face. But every one of you out there who is doing this, everybody on the panel who's doing it, we know it works. Scientific method says whatever I do in my office, and you can repeat it, means it's evidence-based. It doesn't have to be a study where we have a control, and that throws what we do back at us through the medical community. And what I throw back, show me what I'm doing is wrong. Okay, scientific plausibility means what we're doing has prior probabilities and it's building blocks for new data. So randomized control studies shouldn't be the gold standard. So I'm sorry, I know everybody talks about it, but experience and repetition and everybody's ability to repeat what I do and what you do says that's a good randomized control study as far as I'm concerned. The dean of the dental school in Buffalo, who was, I don't know if he's still there, I don't think so, he did an article on randomized control studies and talked about, I have invented something that's called a parachute. And I'm taking 20 people up in my parachute, 20 people with a backpack with nothing. Those with you with a parachute are going to show that gravity will break your fall. The rest of you are going to die. So we can't do with a human a randomized control study because we know the facts will cause death. It's imperative that when we see these babies and we do our studies, that we come up with a way to do it to show you. We can do it retrospectively, but actively, we don't need to do that randomized control study because it's unethical. Okay, we have a window of opportunity here. We need to work as a team. And the whole team works together. But if that team has failures in it because of egos, starts with the OBGYN or midwife, and then we have the medical community, then we have the dental community, then we have the myofunctional therapists, depending on ages, feeding specialists, okay, body workers, our lactation people, and speech and language, okay? When we work together and nobody says, mine is the most important and you have to see me first, okay? So I don't like that stuff because when we look at a baby and we look at what's going on in that mouth, we have to make a judgment. And remember, physicians and dentists are the only ones allowed to make a diagnosis. Everybody else can assess. However, let's talk about assessment. Under the ideal set of circumstances, we have a chain. And birth of a baby, we have OBGYN and family, they're going to see the baby first, okay? Or we have our midwives. And what happens is, on a class 1 or 2 tie that I call, they're minimal. I don't use the word posterior tie anymore. I've changed it to distal because everybody thinks a posterior tie is insignificant. Okay, they go to their IBCLC in the hospital, which has usually got a gag order on her. So if she's good, she'll send you to a private IBCLC outside the hospital, who will then make a decision and say, okay, let's see a body worker, and then we get you to the surgeon. This is ideal. However, when we have a class 3 or 4, we're spinning our wheels. You can't stretch the tongue frenum. That one goes from the midwife or the doctor to the surgeon, especially if it's class 4. We work with our IBCLCs and our body workers, and we go back to us, but we cycle. We go together. We work as a team. We work and assess and get a second opinion with the surgeon. And we're the ones doing the surgery, and we're the ones who make the final decision on where to cut and how to cut, not somebody who is given an assessment. We're dealing with a window of opportunity of days and weeks, not months. Why? And I'll show you why. And I have plenty of proof on here. Okay, we can avoid problems. The problem is those of you who assess are making a diagnosis. When you tell a patient there is nothing wrong, that's like me telling a parent, you don't have tooth decay without taking x-rays. And they go someplace else and they get a different diagnosis. So your assessment is like a nurse who looks at the patient and says, oh, you're getting up a lot at night, you're peeing, you're drinking, you have black and blue spots. Maybe you might need to see your doctor to rule out diabetes. So the assessment means you're looking at the symptoms, you're putting it together, and you're saying, okay, the next step is let's get the proper evaluation, and we work together. The primary link here is medicine. And this is from the Breastfeeding Medicine, Academy of Breastfeeding Medicine. A significant missing link to our physical diagnosis and education is basically observing breastfeeding and understanding the impact that this has on an infant's latch. Okay, physicians in training don't get this opportunity, and this leads to problems which is indefensible. I'm sorry, it's indefensible. Okay, so Dr. Gahary wrote a nice article, and the medical community said it was no good because he didn't have a control. Richard's done articles. You can read all his articles. He's got them there, and they're excellent. I'm glad he has the time to do it with everything else he does. These are articles which you can read, but there's plenty of stuff out there which the New York Times basically ignored, but they talk about milk removal, sucking, and adequate degree of mobility of the tongue. These are more articles. You wanted articles. There's plenty of them out there. But the conclusion of all of these is things improve significantly, either immediately, a week or 2 weeks. As Richard said, it could be 3 weeks. That's why we have a team. That's why we work together. But again, we have to pick and choose when we're going to work together. Not when we're going to work together, but who is going to make some of the decisions on the surgery versus not. And for the most part, I see over probably close to 2,000 babies a year, or I should say 2,000 children who are in need of this. And most of the time, they're tongue-tied. Okay, some get to me before myofunctional therapy. Some drive hours, 10 hours, fly cross country. And I'm not going to say I can't do it. I know there is some people out there in the medical community who refuse to do it unless they're referred in immediately. That blocks off a whole segment of the population who can't afford all of these other excellent participants in what we're doing. But again, these are more articles, and you need the names on there. They're all people we know. They're all people who we've met. They're all people who we've worked with. Okay, and they're all different journals. However, obstructive sleep apnea, we see this on kids all the time. Tethered oral tissues is a differential diagnosis. The trouble is the medical community ignores the tongue as part of their differential diagnosis, and they go right to drugs or the OR to ENT, and they get told there's nothing wrong, or they do it. I've never had to put a child into the operating room. Now, unlike Richard, I don't have parents in because I feel the surgery warrants complete coverage of coats, heads, hair, glasses since COVID, and I can do it I've had parents come in and pass out. I've had parents come in and start crying. So I can get that child away from the parent for under probably 5 minutes and back. And as soon as I bring them back, they start to latch, and the mothers come in crying because they're upset because what we have to do, but they leave crying because they're happy because we fixed the problem. The first thing I tell a mother is, it's not your fault, because they're told they're a new mother and the blame is put on their shoulders. So first thing I do is try to calm the mother down and say, you have an anatomic defect in the child because something didn't disappear. And what we want to do is we want to make it so it's fixed, but it's not your fault. Don't let the medical community or other people in your family blame you. And it takes a load off of their complete neck and back and shoulders. So what do we use for criteria? There are a lot of different things out there, but you know what? The bottom line is 3 ways. Way number 1, simple. It takes 1 minute to do the evaluation for the most part. You come in and they've already filled out the form, which we'll talk about, but we want to look at mostly anatomic. Now, as Richard has said, patients come in with a tongue tie like this and claim they've had no problems. When you release it, suddenly it's, oh, I didn't realize it was supposed to be so pleasant. We also want to take a look, and we want to look at the ability to function. But most important is the comorbidities. And I'll thank Kevin for this, because in conversations with Kevin, we got rid of the word symptoms and we call them comorbidities, because there's so many different symptoms or comorbidities, and they can all be related to one problem, but they're all treated individually and separately. So it starts with this, and you can download this from my website, okay? And this should be part of every physician's new baby 1 week or 2 week post-op. We want to look at the comorbidities. We don't want to waste thousands of dollars on endoscopies and hospitalization and drugs and medicine. We want to treat the cause. That's really what's so important. And there are plenty of the studies as I showed you. This is wrong. The tongue does not stretch. It might tear if it's an accident. And babies who are gaining weight when they're tongue-tied, it's because the mother is waterboarding the baby. Literally, the baby looks at the mother and squirts. So I have babies come in, well, I wasn't going to come because my baby's gaining weight and everything is fine. But you look at all the symptoms they check off, and the one on the mother's side is oversupply. They're just waterboarding the baby. You don't need a study to prove that. It's obvious. The wrong information is given for tongue ties or lip ties. Okay, the baby will fall. That's not going to help the nursing mother. Not only that, but each one of you out there, by law, is a mandated reporter of child abuse. 65 to 70% of physical abuse involves the head and neck and maxillary frenum. Okay, look at all of the people who are mandated. Are you going to send every kid who falls to Child Protective because you can't determine? So New York State has just mandated we take it. And I'm having a conversation because they asked me to do a course on it. And I said, well, before you do that, I've testified where they said I can only speak out what goes on in the mouth. So when a kid comes in with a torn frenum, I look at the back, I look at the arms, I look for any kind of signs of cigarette burns or other damage. But in a court of law, if it's a good lawyer, he'll object, Your Honor, he's only a dentist, only a dentist. I spent the last 2 years developing something to keep the parents' hands out of the mouth. I've done over 40,000 surgeries. I've never seen an infection. They don't need to wear gloves when they're home. They have to wash their hands. But this is an instrument which all of you, and I'm a little disappointed that only one physician is on here, but doulas, midwives, speech, this is a great instrument. It's non-reflective. It's great for surgery. We've really got another one out there, which we're working on for sleep apnea and things like that. But this allows the parent, and you'll notice I have a much better vision when my hand isn't in the mouth, when I have a laser, which is outside the mouth and can go in. So this is an instrument. If you're interested in Armor Dental, works with me on it, or you can go to my website and get information on it. My protocol for an exam is this. I have the parent hold the child. We have 4 consultations. She can see everything I'm doing. This way, you can't. There's no way to make a diagnosis. And that's why only 5 to 10% of babies are listed as tongue-tied because the studies are wrong. They can't do it. They can't show that there's a tongue tie primarily because they don't get their hands into the mouth and touch and feel. You can't see it this way. You need to get in there and look. And there was a study, okay, that said, it's on the next slide, I think. This is your posterior or distal tie. If you look at the first slide, you can't see anything. You got to get your fingers in there. Push down. This is the same tie on the left and right side. Parent comes in with the symptoms, you have to be able to evaluate it. That's why you can't do it through teledentistry unless the parent can do that, and they can't do it. Okay, this is, anybody can write a peer-reviewed article. This is one, I've been doing this for 50 years. Okay, somebody wrote an article showing how I've been doing it, and they said 30% of these babies were tongue-tied. Now, 40% or more babies have reflux, and reflux goes away almost 90% of the time when you release the tongue, because it's air-induced reflux, which Scott and I wrote articles on. Okay, and they're on my website too. Older kids, we just have them stand up in front of us, okay? Because they can get a good look at the lip and the tongue, and they're not lying in the chair. We do it with the parent standing there. We show them what's going on, and they get a good view. So our informed consent involves showing the parent. They watch a 15-minute video, which covers pretty much what we're talking about tonight. And I answer any questions, but this is how you want to do it. And the older kids, the adults, teenagers, we do in the chair. Okay, so clinical observations of the lip. You've got people teaching IBCLCs who say the lip doesn't do a thing. And I would totally disagree. You'll notice the upper lip bends in. They don't get a good latch. Okay, it took me 2 years to get this published. And back actually in 1979, I published one concerned with tooth decay and was told that by some very prominent IBCLCs that not only does mother's milk not cause tooth decay, but it helps, if they do get cavities, fix them, and that's wrong. And if you're the mother and you've done this, and I'll show you what happens, but look at this baby on the left and look what happens after we release the lip. You notice the lip flanges and it doesn't hurt. And a lot of times we'll say there's nothing wrong until the teeth come in, and that's when the baby starts biting. I know I'm talking fast, but I got a lot. All these things here, these are babies who were just breastfed, and in some cases we're told by the pediatrician it's just dirt on the teeth, it's staining on the teeth, nothing to worry about. And when you're a mother who thinks you've done everything right, and you see this, 3 things: at will nighttime breastfeeding without wiping the teeth off in conjunction with a lip tie, class 3 or 4 maxillary ties, they get facial decay. Okay, you can deny it, anybody out there, if you want, but I got to fix it. Okay, and I do. The concept that we don't release the upper frenum because we need to do ortho first started in 1953 by a military orthodontist. And it's been repeated over and over. It's in my textbooks from 50 years ago, but there's no science behind it. Okay, I can't show you tonight because I don't have enough time, but I can show you releasing it allows the teeth to close. And if you really want this whole lecture, which is 7.5 hours, on February 9th, I'm giving the course, and I'll mention that at the end of the lecture. Brian Palmer, who unfortunately is no longer with us, wrote tons of articles and slides that documented all this. They just took his website down. It was up there for almost 10 years after his death. But he was one of the foremost people out there who talked about the infant's ability to latch, and it's the best way to prevent sleep apnea, and it's the cheapest form of healthcare. So again, this is a kid who comes in, and if you look carefully, you start to see decalcification of the enamel. Because milk is pulled up into the folds. Now this is a diode, and I also took a handpiece and I disked the tooth and put the kid on topical fluoride. And we took care of it. Now, how do I know it's not something else? Because there are some congenital defects. Well, you need to know the eruption sequence and what you have at birth that's in the mouth and what you have at birth that's below the gum line. So you know the upper centrals and lower centrals are beginning to calcify in utero, and at birth they're already formed. So when you start to see decay on the permanent and primary centrals and lowers are fine, you know it's in the environment. And we could talk about dentinogenesis and amelogenesis and hypophosphatasia due to vitamin D deficiencies, which some vegans do, and their kids suffer the consequences with rickets and tooth decay. I wrote an article on this again, and it took me quite a while to get it through my IBCLCs in the medical community because they didn't want me to call the maxillary frenum ellipti. Reflux drugs, okay, they're not recommended. The FDA doesn't recommend them. They have tremendous amount of side effects. And the physician's first thing is put them on a drug. ENT, put them on a drug. GI doctors, put them on a drug. Do you think they would ever call up and say to me, Dr. Kotlow, we're going to start looking at the tongue because you could save these parents so much grief. We send every physician a copy of the tongue tie before, the symptoms, and what's after, and nobody responds other than the parents. They're the ones who are going to change what goes on. What do they say? Babies normally have distended abdomens. They put them on reflux, or your mother's allergic milk. They put on an elimination diet. They go to a GI doctor. They put them on more drugs. Or if it gets worse, you know what they do? They do surgery in the hospital or put an NG tube or all these things are what the physicians are telling my patients. I look at them and say, I don't believe so. Let's release the tongue and see what happens. It's not part of the differential diagnosis. I'm not saying the tongue cures everything, but it cures an awful lot because it's not just a muscle. It is an organ, part of an organ system. 15 different symptoms. Okay, we're going to keep going here. This is a baby who comes in, sees a GI doctor, mouth breathes, drooling, there's a tie, the lip revised, okay, the tongue. That's what he looked like immediately after. Look at all the differences after the release, okay? And again, you're gonna have to read quickly because I don't have a lot of time left here. And I want to get at least another 6 slides or so. This is a 7-year-old. You can download this from my website. We give every child above the age of 2, when I do the exam, if I think there's any kind of degree of restriction, I have the parent fill this out. The middle section, they rate 0 to 3. Okay, and you can see all the 3s. And look what they've seen. 3 IBCLCs, like body workers, ENTs, sleep study, 2 pediatricians. I have no faith in sleep studies because this is more important. I want to know the symptoms and I want to get my fingers in them. Okay, we look at the tongue, we see all of the different symptoms. Simple release, and look at the stature of the patient. Look at the neck before and look at the neck afterwards. So it does affect the degree of spinal integrity when the patient's lifted their head up, because when they have a problem, their neck comes forward to open the air. We could talk about grinding because that brings the jaw forward, and it can last a lifetime. We have oral dysfunction. Okay, this one was referred, and I'm only going to show you the first part of it because this will take another 3 minutes. But this is 2 years later, but listen to her. This is with just topical anesthetic. You got a clear view. This is before I use the tongue guide, but the laser's outside of the mouth. My hands are outside. I have perfect view, and I'm able to control the tongue movements. And I did that with just topical anesthetic, low-level laser therapy. Keep going. Okay. Keep going. Yeah, move it left and right. So that's a week later. Again, I don't have time to show the whole video, but basically said for the first time in years, she slept through the night. The brain scan, this is a series of study out in San Diego. The baby's brain is growing 1% each day after birth. The first 90 days is vital for that baby to get that tongue corrected. Not 6 months, not 2 years, but the first 90 days. So if you're screwing around trying to change that baby by just body work or just position in a class 3 or 4, you're wasting that patient's time. And the brain, once they lose neurons, they don't come back. And again, all of this stuff in 30 minutes is hard to give you because it's each one of these parts of the tongue and its function could take a couple hours for us to go through. These are more articles, again, about breathing. I know you'll all know who the next one comes from. I actually met Christian at a meeting in Chicago when we talked together. Lastly, let's talk about autism and ADHD. When my kids were born 50 years ago, my daughter had a TNA because her tonsils and ears were always infected. Okay, but medical community and insurance controlled it. Historically, they stopped doing them. And then what happened? ADD, ADHD, and autism became the new fad, the new fads. Okay, that's the fad. And basically, they stopped doing them. So let's think about it. Again, speculation, but could this decades-long problem of decline in opening the airway be causing the problems? Not immunizations, not foods, and not all the other things people are trying. Maybe it was medical neglect, malpractice as far as I'm concerned, because they're still doing. Okay, speech. I just gave a 2-hour course to the New York State Audiology and Speech Organization in April here. And when I looked at their courses on tongue, it wasn't very complete. When you spend 3 or 4 years trying to correct a tongue tie when it's tongue tie, speech with a tongue tie, it can be fixed quickly by cutting this tether and giving free function and mobility. Okay, that's the key, function and mobility. Peer-reviewed articles on speech, there's not a whole lot of them out there. It's pretty much ignored, but these are some of the ones on speech that are out there. Okay, so it does show that speech is affected by the tongue. Surgery-wise, we hold the baby this way. We do not allow parents to hold babies, okay? Because if you got a problem with bleeding, they can pass out. And I want to put full concentration on my babies. My assistant's been working with me for 46 years. And we use what we need. We get the baby taken care of. And we do the surgery. It takes us less than 10 minutes. The baby's with us, but the baby is swaddled. My assistant and I can control the head and neck. We use extraoral suction with lasers because there is a significant plume. Okay, so this is the entire thing. You can't see the surgery, but that was the entire time it took us to do the tongue and the lip. Okay, I'm out of breath. I finished it. And in a little more than a half an hour. Thank you for your attention. I appreciate I didn't say thank you for inviting me because we had so much time getting on, but this is my book. You can order it on my website. You can order it through Amazon or call my office. And this is the course I'm giving. I'm giving it February 9th. It's a Friday from 9 until 4. Get credits for it, 7 credits. And it's supported by Convergent, but it's all my course and they have no control over content. Okay, well, thank you. I didn't get a chance to look at any questions or answers, but I will release you guys from what we're doing here.
Wonderful. Thank you so much, Dr. Kotlow. That was so helpful. And the good news is that this is recorded and everyone will have access to review. And your website is a wealth of information. We always refer to your website for the references. So thank you for all you do. And if you want to, you can answer. Thank you, Dr. Baxter, for answering the questions during some of the presentations. There were a lot of them. I'm impressed. You're a fast typer.
Can I say a couple of other things? I want to say a few other things, okay?
Please.
When you use a diode, you have to be very careful because if you hit bone, you can cause bone necrosis. So the difference between CO2 and erbium is you can't get bone necrosis. There's a difference between hard and soft tissue lasers. We do a facial massage before we even go into the mouth. If we do get any bleeding when we open it up, we have a 2x2 with some Afrin on it. We hold it on there for 30 seconds. That'll stop any bleeding. And to get the older kids to do the exercises, we have them put peanut butter in the roof of their mouth and lick it. And that's a parent way of getting it in. So that's just a bunch of quick things. All right.
Wonderful. Thank
Thanks,
you so
Larry.
much.
And we don't
Thank
have
you.
parents back for babies. Like 12 months and up, we'll have them back. We try to do what makes them cry least, but sometimes if we'll just have dad sit in the corner or something because we don't want them passing out either. But yeah, it's a good point.
Wonderful. Okay, so let's proceed, and we're going to talk a little bit more about the risk-benefit ratio by Dr. Scott Siegel, and I'm going to go ahead and give him his bio for you all. It's Dr. Scott Siegel is a board-certified dual-degree MD DDS oral and maxillofacial surgeon. Dr. Siegel is a fellow of the American College of Surgeons, International College of Surgeons, and the first oral and maxillofacial surgeon awarded fellowship to the American Academy of Pediatrics. Dr. Siegel is also an active member of numerous medical and dental professional organizations. Dr. Siegel has over 25 years experience as an oral and maxillofacial surgeon and has devoted the past 23 years to treatment of issues related to tethered oral tissues. Dr. Siegel has performed over 30,000 tethered oral tissues, including 4 of those are which my family members, so to date, and is an internationally recognized pioneer in the field. Educated at the State University of New York at Stony Brook Schools of Medicine and School of Dental Medicine, Dr. Siegel is the medical director of the Center for Tethered Oral Tissues based in New York City and Long Island, New York. During his surgical residency and in private practice, Dr. Siegel was mentored by world-renowned pediatric surgeon and tongue-tie pioneer Elizabeth Betty Corollas and assumed her practice upon her retirement. Dr. Siegel lectures internationally and conducts clinical research and publishes on topics related to TOTS, including aerodigestive disorders related to TOTS. And Dr. Siegel is known for his work regarding aerophagia and utilizing ultrasound and understanding the kinematics and tongue motility before and after phenectomy. Dr. Siegel is currently working as a clinical investigator in 2 major IRB-approved clinical research projects, and he is working in collaboration with the Department of Biomedical Engineering at Columbia University and Tel Aviv University in understanding the kinematics of tongue movement in infants, children, and adults with ankylosing. And Dr. Siegel is also working with the child development. Wow. What do you do in your spare time? So thank you so much. We're so thrilled to have you here, Dr. Siegel. Take it away.
Thank you, Lauren, and thank you, Larry, Richard, and the rest of the panel. It's an honor, privilege to be here tonight. I just love listening to both of you, Richard and Larry, and I can do it for days. I can't wait for the next conferences with you guys. My speech or my talk tonight, I'm gonna keep it on the shorter side because I think we'll get more from some of the panel discussions and questions and answers. But what I wanted to kind of circle back with was risk versus benefit of what we're doing, and try to give some pearls to our listeners here to go back to families or to be able to speak to other healthcare providers about what is the true risk and the true benefits of what we do. Going back to understanding the informed consent process, I don't want to really harp on that New York Times article, but this is an important part of talking about that article, risk versus benefit. And when I had the opportunity to speak to the journalists, this was a big question, and it was ignored. And unfortunately, they just really kind of had the fear-mongering agenda of talking about risks and not understanding, the benefits. But when we talk about medicine, dentistry, surgery, most things in life, we're always talking about, what's the bad, what's the good of what we're doing. Specifically talking about risk versus benefit, there are a couple of things that we need to understand. The risk-benefit ratio is a ratio of the risk of an action to its potential benefits. The risk-benefit analysis is the analysis that seeks to quantify the risk and benefits, and that comes up, leads to the ratio. Analyzing risk is really kind of heavily dependent on us as humans. And what I may see as low risk in my practice may not be the same for someone else. And I can kind of circle back to that picture that Richard showed of that baby that had burns in the mouth from a diode laser and silver nitrate. That would not happen in probably any one of our practices here. But that is a known risk out there, and it's published, and we need to talk about those things. When you go through medical school, when you go through dental school, and or understanding as another healthcare provider, whether it's an SLP, OT, IBCLC, anyone who's dealing with treatment of patients. From a surgical standpoint, this is something that's, out there. You go through residency training, you go through all of our training, understanding, when do we do a procedure? What is the risk and what is the benefit? This is a pretty interesting article talking about, surgeon perception of risk and benefit and the decision to operate. So when you go out to conferences and we lecture to, new grads or people who are really motivated because they just got their new laser and are ready to, hit that nail with their hammer, because everything is, becomes something that tool needs to cut. It's something that we really kind of have to understand, the perception of the true risk and the benefit, and that will influence our decision to operate. And when you look at a study like this, which was published in the Annals of Surgery back in 2016, the objective was to determine how surgeons' perceptions of treatment risks and benefits influence their decisions to operate. The background is little is known as what makes one surgeon choose to operate on a patient and another choose not to operate. When you're talking or we're preaching to the choir here tonight, it's a different audience than when I go and lecture at the American Academy of Pediatrics. And I know Richard said he was on a Zoom call with them. I had the opportunity to present to the American Academy of Pediatrics in 2016, and it was not a very friendly atmosphere. And part of it was because of the perceptions of risk and benefit of what we're doing here. So when you look at the conclusions of the studies, and this is just one study here, there's multiple studies if you start to look in the literature about risk-benefit decisions. Given the same clinical scenarios, surgeons' perceptions of treatment risks and benefits vary and are, basically highly predictive of their decisions to operate. When we look at true risk and try to understand what we call risk stratification, it's how do we determine and minimize risk? So what I really wanted to do was talk about, a general family that comes in for a consultation, and how do we sit there and speak to these families and go over the risk versus the benefit of what we're doing. When you look in the literature, there's some generally accepted risks of a lingual frenectomy. What are those? For the most part, most of us, I can post my informed consent, but most of us in our general informed consent are going to talk about pain, bleeding, swelling, infection, nerve injuries, salivary gland injuries. These are all things that have been documented in the literature. The true risk of what we typically see, or like Larry said, in his past 50 years of treating, children in the pediatric population, he hasn't had an infection. I haven't had an infection in my practice either. There are reports of infections in the literature, and we're not sure exactly what's going on to have those happen. But we do get pediatricians telling families that, it's much more likely to have infections because it's the mouth, it's a dirty area. When you look at the true risk of nerve injuries, salivary gland injuries, they are reported out there in the literature. I have a couple of reports that we'll show here, just so you can have it for completeness here. But they're rare. So when I do a general consultation and I talk about true risk versus benefit in the baby, and I'm going to really just talk about infants tonight. And I do treat from, the hours old up through senior citizens in my practice, dealing with these issues. But what I really wanted to talk about was kind of counteracting that New York Times article, which is really focused on babies and breastfeeding and bottle feeding, and the fears that kind of come about as far as the major risk, because we'll hear it many times from the family's pediatricians saying, it's a dangerous procedure. It's just being done just so that, a doctor can make money. When they're not helping the baby, let's put the baby on reflux medications, or let's just, give them formula in a bottle versus breastfeeding. I'm not saying that there's anything wrong with formula in a bottle or anything to that effect, but we see a lot of families being steered in the wrong direction. Scarring or reattachment, very unlikely to happen. I saw a question earlier posted about fiber scarring. You can have all of these issues in your practice, but they're rare. And then we'll talk about how do we minimize these things and talk about, determining who is at higher risk for a certain potential complication and how do we deal with those things. So scarring or reattachment in my own practice, it's very low. We see around 2%. And that over the years, we have basically kind of come to the point of minimizing by information, swapping with other providers. We're having a difficult time performing the research, like Larry said. The evidence type of based research that pediatricians are asking for, these double-blinded, randomized, clinically controlled studies, we cannot provide in these populations. So our scientific plausibility, understanding active wound management, stretching versus not stretching. When I did not do stretching or some sort of active wound management in my practice, I had higher reattachment rates or scarring than I do now. Feeding difficulties or disorganized feeding or aversions, quote unquote, we see very unlikely as well. Unfortunately, that New York Times article, that was the sole focus of the article, was talking about feeding aversions, and what we're doing is causing more problems than helping with. Breathing difficulties, understanding when to cut or when not to cut. Very unlikely that you're going to cause some sort of breathing difficulty, but it's reported in the literature that babies can have difficulties breathing afterwards, or I hear it all the time from pediatricians or other healthcare providers that you're going to cut the tongue and it's going to fall back into the airway, and then the baby's going to, choke and not be able to breathe. That does not happen. Or if it does happen, it's in a very rare subset of patients, like the Pierre-Robin sequence patient, the patient with micronathia that does not have any tongue space for the tongue to move forward or up, and it can obstruct the airway. So this stuff is out there, okay? And I'm posting a couple of these articles so the providers here have it in their armamentarium about quote unquote major complications after tongue tie release. So that is you look at that title of that this journal article and you think, what happened? And basically this is an abstract or an article talking about the procedure of tongue tie release and what it can cause. And this is basically a case where a mucocele formed under the tongue. It was not a major complication, but it's a complication and it's out there. And I think one of the things that we have to kind of understand is when we look at the ability for us to kind of come together as a specialty, is to be able to understand, when complications do arise, how do we take care of these things? There is very little reporting that does happen. So and understanding the true rates of complications and true risk of a procedure, especially when we're dealing with tongue ties, it's very difficult for us to kind of have a full objective handle on at this point. This is another series of cases when we talk about bleeding and we talk about that as a risk. in my own practice, I've not had any major bleeding episodes. And we talk about even, there was a question about vitamin K. We'll talk a little bit about that in a little bit. But this was a series of patients that was published in the literature. And I've had pediatricians talk about this, where there's been significant hemorrhage. And there are reports, there's a report, I think in the United States as well, where there, and maybe Australia, that there was significant hemorrhage after a procedure. And there was this was a article that talked about, I think it was 4 or 5 cases in Nigeria, that babies had to be transfused after the procedure. Very unlikely, but it's out there, and people have to pay attention to this. Complications. So this is an article that is in our literature. It's out of the International Breastfeeding Journal, and talking about complications and misdiagnoses associated with infant frenotomy. And this was a healthcare survey. I don't know if people know some of the authors here, but they're pretty well respected. I know Yvonne Lefort personally, and she's an amazing tongue tie provider, as well as a breastfeeding medicine specialist as well. But what I really wanted to talk about here was that there are people who are trying to kind of understand what are the true rates of complications or risks in these procedures. And what I'm posting this here, I'm not going to get into the details here, but what I wanted to drive home, let's move through this a little bit faster here. What I wanted to drive home was, it's not about, the type of instrument that we're using. It's not necessarily about, the procedure itself, but it's understanding indications and understanding true risk and benefit. This study, which was it was put out there and had some pretty significant limitations, because it was a retrospective survey and it was limited by recall. And it was an online survey that looked at a group of respondents that's likely not representative of the population of healthcare professionals caring for infants with ankylosing. But when they publish a study like this, what it does, it starts to give more ammunition to our, I don't want to say our enemies, but the ones who are more skeptical about what we are doing out there, and saying that, oh, look, there's a big study out here showing that there's major complications happening in these babies. There's bleeding, there's infections, there's inability to latch. So what I'm kind of calling for is, more data collection by all of us here. And I think we can talk about this in our panel discussion, because I kind of want to use this as a segue for further discussion tonight. We got amazing presentations by Richard and Larry about the actual procedure, how to diagnose or how to look at a tongue tie. And by no means is this something that you take an hour and a half course and you're ready to go out and treat tongue ties. But what we need to know is, what is the risk? What is the benefit? How do we make decisions on when to cut and when not to cut? The informed consent process. Essentially, when I speak to a family, I'm trying to make this a shared decision. I give them the information and in real time help them understand what is our experience collectively as a specialty, what is my personal experience in my own practice, and what are we seeing and what are we striving for as a team. And that team is the family, and it's it can be it's the baby, it's the mom, it's the dad, it's the lactation consultant, it's the speech therapist, it's the whole team that's helping make this decision. And when we talk about the informed consent process, we're giving out as much information about that risk benefit ratio and in order to allow that family to make an informed decision for themselves without pressure. And I think that's one of the things that, I was really taken aback based on that article. And I don't want to keep going back to that, but it's an important point for us to move forward with is some parents are feeling very vulnerable, and it's a vulnerable population. And we need to make sure at every step of the way that these families feel empowered. You cannot silence those families out there that have a bad experience. And there's in that journal, not the journal, the New York Times article, there was one of my patients that they sought out that didn't have a good experience. It happens. We try our very best to make sure that doesn't happen. But things do happen, and we're trying to understand when, is that likely to happen, and what can we do to help rectify an issue that does start to happen? If it's not, I'd hate to say these are complications, but maybe it's an event that you did not anticipate, or it's an outcome that you're not anticipating. So what are those specific risk factors in helping to calculate those individual risk benefit ratios? So when we look at a general consent, and then we start to look at the specific individual. And I had this conversation specifically with the journalists because there was a question that came up. It's like, how come when you're speaking to a family in general, you don't talk about oral aversion as being high risk? And what I said to them is like, in my own practice, it's not a high risk. In what I see on a daily basis, I can count on, my one hand in the past, decade, how many cases of an oral aversion or real feeding difficulty you have. But on the flip side, I do research. My colleagues that are really getting the best results, we are looking at understanding on when is the best timing to release a frenulum, if it needs to be released, who to cut or not to cut, understanding the medical history of the baby. Is there some sort of, comorbidity that is preventing us from or helping us shoo away from cutting at that specific time? Is there his family history of bleeding disorders, birth trauma? What's the exact nature of the feeding issue? So it's not one little piece of a puzzle that you're focused on. There's, multi, factorial issues. And being a doctor is not being a technician. And you are basically have that family and that baby's well-being in your hands, and understanding when is the best time to, move forward. And that being said, there's no one uniform consent process for each patient. It's different. When I speak to the families, when I speak to other doctors or people that we're educating about this whole process, we say each of these patients is a snowflake. What looks like a slam dunk case may not be a slam dunk case. And we have to make sure that when we have newer providers out there who are understanding, this whole process, they went to, Dr. Baxter's course, they did a great laser course, and they're ready to go out there and cut. It doesn't mean that you fully understand everything is, going to be just a honky-dory sort of cakewalk. And I say that based on my own experiences. I've been through a lot of ups and downs. We talk about risk versus benefit, and you talk about complications. Earlier on in my career, it was my mentor's patient, Dr. Carrillos, who towards the end of her career had a significant hemorrhage in a baby that did need to be hospitalized and transfused. So these things do happen. And what sets us apart as an experienced surgical provider is understanding proper surgical indications and your own limitations in order to minimize risk. There are so many cases at this point that I turn away, or, trying to understand when is it best not to cut. I was doing research with ultrasounds with Kathy Jenna, who's a very well-known lactation consultant. And one of our goals, and we tried to drive this home with a journalist, is to understand, when is it best not to treat a baby surgically? And I'll go back to Richard and Larry's lectures here. Each of those cases, I would agree, I would have cut and released those babies as well. There's a subset of babies that, we're kind of on the fence with, because maybe they're not dealing with a true frenulum restriction. Maybe they are dealing with some sort of other issue going on, whether it's a torticollis, physical set therapy sort of thing. I think Richard alluded to, something going on with the nervous system where it's more of a fight or flight sympathetic drive going on here, and trying to understand, when is the best time not to cut. And that's one of the things that we try to drive home when I'm, teaching newer providers out there, when we go to lecture about this, because it becomes very exciting when you see a frenulum that looks so obvious. I need to treat it immediately. You have to be careful and just make sure that you're understanding risk and benefit and understanding potential complications. We don't want to live in denial. Okay, so as a doctor, if you do have a complication, and complications do occur, we need to address it head on, and you need to be honest and open. And I talk about being honest and open with communication with the family. So you need to be understanding of the family and their fears and what they're going through, and to be there supporting. And you need to also be able to speak to whoever is part of your team, and understanding the more you communicate, I think the better the outcome and the less likely of having an adverse litigious event against yourself. So, it's kind of practicing medical legally defensively as well. Timely referral to another specialist. If you're unable to adequately deal with any potential complication that you have going on, you need to know, I need to get this baby out or get this family to see somebody else, and get another opinion going on. When you start to share that responsibility, the burden on you starts to be lessened. And I also, at the same time, I think the respect for you as a provider, as a doctor or a healthcare provider, starts to go up. And I will have families, reach out to me. It's like, what's going on? And it's like, I'm not exactly sure, but let's figure this out together and let's move forward. Follow up in person. And that's not always something that can happen. Larry spoke about people traveling from, 10 hours or people flying in. We can't always see our patients in person. And although I try to desperately, because I really want to get hands-on, if you cannot follow up in person, make sure you're following up, at least video is the next best thing to do. And I really kind of wanted to kind of keep this as a short lecture, get a couple pearls out there. And because I knew the other lectures were gonna have such a wealth of information, and it really kind of gets almost overwhelming when we start to hear this. But I wanted to kind of circle back to opening up a panel discussion, and the questions and answers, because I think when you have close to 1,000 people who register, you don't want to sit there and just kind of be lectured at or lectured to, but you want to start to get, the back and forth discussions that really kind of help answer more questions. The longer I've been doing this, it seems like the less I know. And I think for many of us in this field, it's kind of a journey that we're all on together. In the past decade, to see the growth, to see where we have come together, and yeah, we have some pretty big chasms going on right now between medicine and dentistry and our other healthcare providers. But I think we're also poised to move forward. I think we have, I think Bobby Gahary said every 3 years or so, we have some sort of eruption in the media talking about what's going on, and bad mouthing what we're doing. But at the same time, you have the stories of parents help driving change. You can go on our websites, you can look at our Google reviews and our general reviews and say, what we are doing is helping. What we are doing does work. We're just trying to help move this forward further.
Wonderful. Well, thank you so much. This is so helpful, and I'm really excited to get some of this panel discussion going. So let's maybe stop sharing your screen so everyone can turn their cameras on. We can look like the Brady Bunch. Yeah, there we go. Everyone can maybe come on camera. Our guest panelists as well. Thank you, Dr. Brett Christensen is an orthodontist. Dr. Milton Gavelis is a periodontist. Dr. Ben Morale is a general dentist. Brittany Sierra Murphy is a myofunctional therapist. So Dr. Kevin Boyd is a pediatric dentist. I just thought it would be great to have a discussion here and learn from each other. A lot of these questions are very similar. I must have had 500 questions, but they all seem to come down to how do we collaborate together? What does the timeline look like? What are the pre-exercises like? When do you see the myofunctional therapist? When do you have the post-exercises? So maybe we can kind of start with just the interdisciplinary action. I know Dr. Boyd and Dr. Gavelis, you work together so beautifully. Maybe you can just share your workflow, if you would, with the myofunctional therapist, the pediatric dentist, and then the periodontist doing the frenectomies. Can you give us just a little overview on that, and then we can all chime in?
Kev, you want me to talk first? Well, a lot of times, either one of us, they have to be the quarterback, meaning that you get kids, or of course infants too, but especially kids that we are talking about, we get them from different areas. Sometimes they come from relatives, sometimes they come from the therapist, sometimes they come from a dentist, or occasionally from a physician, especially if there are some of the pediatricians that we work closely with, or nurses, and so on and so forth. So depending on where they're coming from, then a lot of times for me, although they come for me for a tongue tie release, a lot of times we're talking about a lot of other things, more than the tongue tie release. Of course, I check for tongue ties, but I always, anybody 3 and over, like Kevin does, we need a scan. A lot of times it's a very quick scan, very low radiation or anything, but we need to know about tonsils, adenoids. We look at all the symptoms. Like Richard, you said the same thing, and so Scott and Larry, we're looking at all the comorbidity symptoms and everything else there is. My consultation is a lot of time is scheduled for an hour. Sometimes it runs over an hour. And then looking and diagnosing things, then I kind of have a initial treatment plan for that particular child. And a lot of times the first person that they might need to see, besides a therapist that they may already have, is going to be Kevin, or somebody that does what Kevin does, but with, looking at the airway, looking at expansion. If the tongue fills up the whole space, if there is no space for the tongue to go after I release it, a lot of times they gotta make that box bigger, so that they have to see the pediatric dentist or the orthodontist, but usually is a pediatric dentist or a general dentist that is going to do the expansion, open up the airway. The ENT, that was the toughest thing that I had before. It's one thing referring to the pediatric ENT for tonsils and adenoids, is another thing sending them all your notes and talking about expansion and talking about tongue ties. And that's where the collaboration begins, because you need a lot of people, in my opinion, at least treating children more than infants. So, and that's where it starts. And the treatment planning is dynamic. That means it can change depending on the symptoms, the child, the age, and all the things that they need. So that's what I do. A lot of times I just let them know about everything, do my diagnosis, educate them, and then give them the literature, give them the evidence, give them my opinion, and send them accordingly. And I might be the last person that they're gonna see after everybody else is done.
So before Milt was immersed in this and started hating me for pulling him out of retirement.
100%.
No, but he was head of periodontics at Northwestern Dental School. And he, I don't know how many years ago it was, we were in Montreal. He followed me there. I had no idea till I showed up, and there he was. And he wanted to know everything that everybody was doing. He just said it takes lots of people. Richard, all of you guys, Larry, you know, you're dual trained. Yeah, I mean, you can do this and you're a pediatric dentist, but forget it. You know, you guys have become very specialized. Richard's a pediatric dentist too. Milt's talent isn't just with the scalpel, okay, and the diagnosis and the pre-treatment, the post-treatment. Milt's true gift, his talent, is uniting like-minded people to get more kids served. And he's made it his business. We have more myofunctional therapists per square mile probably than any other state, much less city in the country. And Milt has gotten to know each and every one of them. I'm not kidding you. He goes to their offices. He has spent, you know, so much time learning my protocol, and he can explain to the parents, this is why you need this. This is why you need that. And the parents, they just come, not if they're going to do it. When can we get started? I don't know, you know, what it is he's doing, but I really think it is a curriculum that, you know, Dr. Siegel, Dr. Baxter, Dr. Kotlow, Dr. Moralia, you know, Brett, all of us here, you could all benefit from learning how he has gone about doing this, because he's got everybody speaking the same language, and it's not Greek, okay? I mean, this is like unbelievable how much.
All right, well, now you have to share a little bit of maybe give us like a one key takeaway, Dr. Gales. What can you share now that the pressure's on?
For me?
Yes, what's your key?
No, it takes a village. Recently, I was asked to write a chapter on Joy Miller's book and about tongue ties. And originally, she thought I was going to talk about what a great guy I am, how nice is the before and after, and all that stuff. And I said, nah, I'm just going to write a story. And the story is how I started, where I am, what I believe in, and how it takes a village to do all these things. That this is not about us clipping a tongue tie and ending up with issues or whatever. It's more about how, and the thanks, Ben. So it was more about the collaboration and how when a child that either I sent or ended up at the ENT's office, they're not going to look at them like they did a few years ago, at least the ones that I work with, and tell them that tongue ties don't exist, that, you know, those are dentists making money. Actually, we have, and I sent Kevin letters from one of the most prestigious ENTs in our area, pediatric ENT, that actually mentioned that, yes, the child needs tonsils, adenoids, and so on and so forth. However, according to my evaluation, he needs expansion because of airway, and most likely, I mean, he went through that whole story on his letter to the physicians. So this is not only a benefit for us because the ENT is going to accept what we do, is he sends his report to the pediatrician that had no idea, or a lot of times was not supportive about it. And the pediatricians are then very surprised in the letters that they get, that they sound different now. So it's more about taking the time to know, taking the time to gently approach. And I said gently approach because if you push them fast and hard, they're going to shut you down and you're done. And they'll never talk to you again. You have to be respectful. You have to work with the patients, sometimes refer patients to them because they need to. And then that's an opportunity for you to connect with them and explain what you do and why. Most of the ENTs that now they read the reports from the myofunctional therapist, they never read the myofunctional therapy report before. They never returned a call to the myofunctional therapist. They thought that there's no need for therapy. It's all garbage. And even if they did release a tongue, there's no need for not only exercise, nothing. Just move your tongue and you'll be fine. And suddenly now they're reading reports that sometimes myself have to go back and ask the myofunctional therapist because they have so much information and so much knowledge that even I have to ask them questions because there are certain things that I don't understand. So we have amazing people that can help us be successful. I wish the New York Times did an article about that and how Scott, like myself, work with a lot of those people and how we're making a difference, because it's not just us. It's all the support we get, the support the moms get, Richard, the same thing. I mean, everybody that is here, you know, that's what we're doing. I just have been able to approach more the medical community, the pediatricians, and especially some of the ENTs. And that has taken us to the next level. And I think that's one of the big things, because if we manage to get them involved and even present or be a part of what we do in some of our conferences, and Kevin, you know what I'm talking about, and that would make the difference. I think that's what is going allow us to approach the medical community when they have
If I could just mention, if Lauren, just
Please.
this summer at the end of May, the last weekend in May, Steve Carstensen, who is a liaison with the American Dental Association, Richard has spoke with the ADA Pediatric Sleep Airway Symposium. We're in our 8th year now, the task force. The last day they've added a whole half day on the Saturday, June 1st, with the Chicago. This is what they're doing in Chicago, and it's Milt, and it's Darius Slugmani, and it's Jody Walker, SLP, David Wallner, and myself, and we have a whole half day to really. And it's Milt who has designed this whole network. And he did it from the ground. He didn't even tell us he didn't even know he was doing it. And all of a sudden, here we have it. So please try to come to that if you can in June. It's going to be recorded. If you can't come to Chicago, you can go online. Sorry to put a plug in there, but more kids are going to be helped. And Richard, I hope you have something like this. Larry, Scott, Brett, and Ben. I hope you all have a network like this that just can, you all just take care of each other and more kids get served. That's what happens. That's the result.
Yeah, just give them a call.
Yeah, you bet.
So just call the therapist in your area. They often reach out to you and then invite them to the office. I had an OT here locally in Birmingham say, can I come? I said, sure. She's coming on March 1st. Had a pediatrician in Mexico. They're going to come on March 1st too. He has like 160,000 Instagram followers. And he's like the Spanish version of me. I don't know. And he's like super excited about Tongue Ties now. He took Tongue Tied Academy. And he's like getting it now. It's like in Mexico, apparently they're now realizing about tongue ties because of this one guy. So it just takes one person to kind of get on fire for it. And he's a pediatrician. So, and I was going to say real briefly about Scott's, about the risk versus benefit. I feel like you left one key risk out, and that's the risk of inaction, of not doing something. And then they end up in Kevin's office, or they end up like as an adult and they're having all these problems with Brett, with the airway and sleep apnea and everything else, neck tension and like all these problems. So the biggest risk is inaction in a lot of cases, if they have
I
it.
think another thing that's really important to say, Richard and Larry, because we're pediatric dentists, we learn that, we take care of infants, children, young adults, blah, 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 and special needs. Well, I say, there's 3 dimensions to malocclusion. Transverse, Ben always says the maxilla is the criminal, the mandible is the victim. That is, really the least complex to solve early. Sagittal, length, vertical height, and the 4th dimension, which we all know very well, is behavior, which orthodontists get no behavior management training in their residencies because it's implied you will not be seeing them because you don't need to. Any child under 6 years old that has sleep disordered breathing, TOTS, myofunctional disorders, they are special needs patients. We treat them as if they have special needs because they have age-appropriate anxiety. That's just my own suggestion, my own hypothesis, that we need to treat them as if they're special needs because they are, and they can't be ignored. And another thing I'd like to bring up, please, and I'd like anyone's opinion on this. Does anyone think that a restrictive tongue tie or lip tie at birth can self-correct? Now, of course, we don't. It doesn't self-correct, just like skeletal malocclusion doesn't self-correct. It's probably even present in utero. I'd like to hear some discussion, maybe not tonight, maybe for a future, master class, Lauren, but
Sure.
These things do not self-correct, and that's the elephant in the room. There's people that still think that.
Yeah, it's the 12th week in development they form. It's the 12th week in development in utero is when they form. So they're there in utero. I mean, we see premature babies. They have tongue lip ties. Now, 94% of babies, according to Flink, do have a low frenum, maxillary frenum. And so not all low frenum are lip ties, right? Like Larry said, they're not all restrictive. So if it's restrictive and it's causing a problem, but like, again, they're not going to drive 3 hours to see me unless there's a problem. So if they're coming to me for tongue tie, that's probably, but if I was in the newborn nursery, that's different. That's a different population. And so you have to be really careful with that because we do not want to overtreat, you know. We also don't want to undertreat. We try to get right in the middle. But the tongue will stay the same throughout their lifespan. The lip tie will, it's a relative receding as the jaw grows forward and down. And so it does around age 1, 2, 3, 4, 5, 6, it's getting shorter relatively. And so it can look like it disappears. And there's a study that we're trying to get published right now. It's difficult. Can't say where it's submitted, but with Zoggy and Audrey Yoon. And so we're trying to get that published. It was looking at 1,000 patients and what happens with the lip tie over time as a cross-sectional study. But it does appear the lip tie does seem to recede basically.
Well,
But in a lot of kids, it doesn't.
keep in mind that as the teeth grow into the mouth, they bring bone down with them. And they're going to bring gingival down with them. So the lip doesn't have to recede. It's staying where it was, but the body is coming down. The teeth are growing down. It's when it becomes a periodontal problem, or more importantly, in that 3 to 5 year old group, fight toothbrushing and becomes a panic attack every night. Releasing the lip just for oral hygiene and family tranquility is important too. So
Got a lot of kids.
we're doing patient management by releasing that lip, preventing tooth decay. So even if it's like when they say they'll fall when they're 4 or 5 years old and cut it, that 18 months to 5 years when they're fighting to have their teeth brushed, because every time you pull on it, it blanches and hurts, there's a clear indication to release the upper lip, and it will not recede. The other problem is if it's real tight as an adult, you'll end up with periodontal disease. So, I mean, you've got perio, you've got oral hygiene, and you've got family dynamics, which all come into play.
Yeah. The lip tie affects BP and M sounds, so bilabial speech sounds, as Larry said. And Larry wrote a really good article, I think 2004 it was. So I was like in high school or finishing high school, right? And it was about how
some of these people listening tonight weren't even born when I started practice in 1970.
So anyway, but the gap closes up. Larry was totally right. And we did a study on it. We looked we looked all our patients and it got published in 2022. The gap closes up 94.5% of the time if you do it properly, if you remove the piece between the teeth. But anyway, it's super helpful. We do it all the time for, like Larry said, toothbrushing problems. And then in adults, since this is the airway health, adults, when you release the lip tie, almost every adult we've ever done said they can breathe through their nose easier. It's like they got Afrin because of the fascia release through the midface. Just like when you release the tongue, the fascia releases in the deep layer of investing fascia. And they're like, I can breathe easier through my nose. Have y'all seen that, Scott? Afterwards, they're like, oh my gosh, I can breathe. So I'd like a study on that. Brett, you have that like rhinometry. I was like, I'd love to look into that somehow, getting the rhinometry involved. Like, I'm not sure if it would pick that up though, but almost all patients, just happened last night or yesterday when I did an adult. So
you also have to be careful when you're doing older patients that you don't do what the oral surgeons do, wipe out the entire anterior papilla. Because if you do that, when those teeth are in, even orthodontic, you have that little black spot, the black hole. So you want to leave a little bit of that anterior papilla behind the teeth so that you don't get that black spot between the teeth. If the teeth aren't like this and they're like this, you get a nice black, like a poppy seed. So you also have to be careful about aesthetics when you do those on older patients.
Yeah. This is like a class 2, 3, like was not bad. And I was like, well, it might help with nasal breathing. She said, okay, give it a try. We did it. She's like, this is crazy. I can breathe through my nose easier. So anyway, that's just a coincidence. Probably it just happened immediately afterwards. So that was a coincidence, I'm sure.
On anecdotal, it works.
Right.
Dr. Christensen, I would love for you to chime in as an orthodontist and your experience. Why don't you share with us, the rhinometry and any correlation with tongue tie release?
Golly, this has been an incredible night for me to sit and watch. I missed a bunch of it because I had 90 patients today and trying to get them and jump back and forth in between them. One of the things I would do, we have like close to 1,000 people on here. And this is my cry for help. I have data I have data of over 1,000 patients that I've treated with expansion in the rhinometer, and the results of it, I've got a statistician that's helped me crunch the numbers to see what the difference of what happens with expansion and nasal volume and the minimum cross-sectional area. I'm just so busy that I don't know how to write a letter. I've never written an article. I don't know how to publish. And one of the things that I am watching, I'm seeing all these articles written, and a lot of the articles are our experiences and our case reports. And in the medical field, they think that's anecdotal, and they don't buy it. I've got physicians that won't accept that. I've got data, and we collect data probably 30 to 40 times a day on my patients. And I just can collecting all this data. And I need help to have somebody that knows how to help me put this stuff together in an article and publish it, because when we publish, then we are going to be valid in what we do. And then I know that Ben and Kevin, and I've got some other doctors around here that have now bought the rhinometer, and I'm asking them to collect data. And the more data we can get from multiple providers is how we are going to validate what we're accomplishing. I know this is a tongue tie thing, and just wanted to share a little experience I had a little kid that I treated with a tongue and lip tie. He was almost a year old, but he was in Kevin's view, he's almost a geriatric patient at a year old for a tongue and lip tie. And he was severe enough, and I told the parents, I said, watch him, because he went for a year or a year and a half, all the time in embryo too. And probably within a year or so, he's going to become a mouth breather. They brought him in last week. He's just now turned 2. And he only had his primary first molars in, but Dad came in with video and saying, hey, here he is. He's snoring. See this? He asked you gasp for breath. And so, originally I was only treating these kids at 3 years old with my expansion, the little Everly expander. But I'm getting more and more of these parents that we're seeing their kids late in life, I'm saying, past a week old, treating these tongue and lip ties. And then we're seeing them back at 2 years old with airway issues. Oh shoot, my thing just went out. There we go. On the other side of this, I've had multiple experiences of parents that are coming in because I treat adults that are coming in for sleep apnea. And I had an experience last month where this dad came in, he says, and we're working him up for sleep apnea. And there's this little blonde gal that's running around. She's 3 years old, and between 3 and 4. And he says, do you remember her? And I said, am I supposed to remember her? And he says, well, yeah, you fixed her tongue and lip tie at birth. I mean, we're at day 4 and you fixed it. And I was like, can I see her mouth? And both mom and dad had braces. Dad was super narrow, I think a 30 millimeter palatal width, severe sleep apnea. And this little girl had big, broad jaws, gaps between all of her teeth, a perfect class 1 bite. And never did I once see her open her mouth. She was a nasal breather. And they said, yeah, she slept great her whole life. And so I have a small population of these little kids that what I should do is now call all the patients that I treated early and get them back, and then say, okay, let's get this data on patients that we have treated and what's going on with their airways. Everything that we've said tonight on tongue and lip ties, everybody that's on here is converted, but now we have to prove what we're doing with the medical population, so that they can get off of their high horse and actually say, okay, you guys are valid, because they're still saying that we're invalid in what we're doing just because we're showing case reports and stuff.
No,
So-
Brett, that's perfect. If you have data, that's really good. I'd be happy to help with some of it. But we had really good data for the lip tight article, right? Like we had photos and measurements and everything, and it was clean data. It was very clear that the gap closes up almost always. We submitted it 7 times to orthodontic journals, pediatric dentistry journals, wherever we could. It kept getting rejected. They said, this is controversial. We're not going to publish it because it went
That's-
against the dogma.
That
So
is
even
so
if you-
shame. Yeah.
So I was persistent though. I finally got it published in International Orthodontics. That's the European Orthodontic Society's journal. So it's not like a pay-to-play journal. It was like a legit journal, and it's been their most downloaded article for the past 2 years.
Mhm.
So anyway,
We have to become the research group. We have to become the ones that are validating what we're doing. So
Absolutely. Thank you so much for sharing that. I just have a quick question for Brittany, because I know we have a lot of myofunctional therapists on, and there've been a lot of questions about the myo sessions pre and post release. I know you do work with a lot of these doctors here. Why don't you just give us like a little bit of an overview on that, please?
Sure. I mean, it's similar to, I think it was Dr. Siegel that had written on there that every patient's a snowflake. So it is hard. There's not like a set protocol for everyone. Most importantly, yes, we want to make sure we're seeing them preoperatively, because sometimes through the myofunctional therapy, we could even alleviate the need to have the surgery done, right? It doesn't matter what it looks like, more how are they functioning? Typically if I'm talking with a parent and they want to know just like a general idea of how long they can expect, usually I tell them it's 4 to 6 weeks of myofunctional therapy before I would recommend the procedure. There's definitely certain protocols that we have. It's also important that the provider that you're working with, that you guys talk about both your protocols. Do they want to have a 2-minute cave hold? What exactly are they looking for in order to feel comfortable releasing this tie? And then post-operatively, usually we're doing 2 to 3 weeks of active wound management and then getting back into working on optimizing their oral function.
Thank you so much. And I do want to take the time to introduce Peter Vitruk of Light Scalpel. They were generous to support us this evening with the sponsorship so I can get those advertising dollars out. So we got the crowd we did tonight. Peter, you want to go ahead and just give us a little bit of an overview on what you wanted to share this evening? I believe you can hopefully share your screen. We didn't have a chance to practice, but welcome and thank you. Thank you for your support this evening.
Yeah, how much time do you have?
Well, we went a little bit over, but if you want the 5 minutes, you got 5 minutes.
5 minutes, okay. All right, let me share the screen.
don't click the whiteboard.
Don't click the whiteboard.
Well, that's where I always click for the share the whole screen. That's where it normally is. So don't just click on your PowerPoint. There we go.
All right, okay.
Yay. Okay.
Success. All right, so now you're gonna go for the just be careful with patient with me. Slideshow. All right, from the beginning. Do you see it?
Yep.
All right.
Yes.
So,
My name is very big.
5 minutes. Let me go under 3 minutes. So Lauren, thank you for the opportunity. And I want to also thank you, all the Light Scalpel laser doctors. And I'm gonna go through the pretty quick kind of recognition. The Light Scalpel, there's no place in this field without our customers. So Dr. Baxter, Dr. Zaghi, there are thousands of the doctors that we owe our success in this field. And since this is the sponsored presentation, there is so much on our Light Scalpel website. Milt, you're here. And, so this is the important presentation on the kind of the value of using the proper instrumentation. If you know what you're doing. Kind of going on from here, my favorite, Dr. Baxter video, and be done. And so this is done with one of our hand pieces. I call it the sharp scalpel, the small size for the incision. And with everything that I knew, this is my grandbaby son. But eyes, lip tie. This was the first time that I was observing the patient in at my home. And these are my heroes. And the amazing thing that I saw, like on his third week of his life, he became the nose breather. So that kind of in a grand scheme of things, the full circle, what we do as the company was the major benefit for my family members. And everyone mentions the infamous New York Times article. Yeah, I spoke to them, there was not a word about my personal family member story, how much little baby Leo benefited from the tongue tie release. Okay, so it's not just the frenectomies with the proper CO2 laser. There is so much more cosmetic surgeries, great many procedures, and of course in dentistry, kind of the rapid fire, going through all of them. Mucoseals, smile design. And so when we are using a little larger spot size, is showing it here, this is the key to a superficial tissue ablation, like what you need for either the leukoplakia ablation or the smile design ablation, or let me get to this, or the gingival melanin hyperpigmentation. Very superficial ablation of the mucosa, and you get all of the melanin out. And the very last of my short presentation here is the most recent, the non-ablative, especially for the soft palate applications. So this is the kind of the application that we are using the largest of our spot sizes. It was developed together with the Dr. Zaghi and with Dr. Strauss. And so the way we articulate in defining what it actually is, we are not calling it an anti-snoring, or kind of the rainbows and the unicorns kind of a procedure. This is the photothermal non-ablative coagulative collagen contraction, staying within the FDA clearances. And so what I have here, very quick illustration of Dr. Zaghi treatment of the soft palate. I don't have much time to show the testimonial. From the soft palate but that was like the 60% at his evaluation that he improved on his quality of sleep. And kind of one of the biggest points that I want to make here is that if you know what you're doing and if you have proper instrumentation, the laser piece is pretty simple. It's the patient selection and all the clinical piece. And this is where the Dr. Zaghi webinar comes in as to defining whether or not the patient is going to be appropriate for that procedure. Whenever a patient tells you, I'm snoring, fix me. In our philosophy, this is not good enough. There is the way more clinical evaluation that you guys need to do to define whether or not that patient is actually a good candidate for that procedure. So quick summary, if you have a proper instrumentation and you know what you're doing, there is the whole range, the whole spectrum of them, from all the way from the non-ablative applications, just shrinking the collagen, all the way down to the incisions, like what you need for the frenectomies and so many procedures in between. And so with this, I thank you for your attention. The best way to find me in a light scalpel is Facebook. Where else? Thank you, Lauren. Thank you, everyone, for your patience. And I think I'm done with my presentation. Hopefully it was under 5 minutes.
Sorry, thank you. I was on mute. It was wonderful, and we do appreciate your support. So thank you very much. It's actually you're our first sponsor of a course. So hopefully everyone got to benefits from this information. I do want to share some resources. I'm going to keep this very brief. I'm not going to go through AHS's full portfolio because hopefully people know it by now. And if you don't, I'm just going to invite you in the follow-up email to learn more about us. But I want to make sure I give you some resources. We know the SOS for Tots book. We always recommend this. Dr. Moralia is a huge proponent of this book, as well as Tongue Tied. We did have a whole presentation that's now public on our YouTube channel, and it dove a little bit more into, we recorded this the day of the New York Times article was released, and we tried to cover it from a fair and balanced perspective. So if you wanted to share that with your patients and get the feedback, we dove into it a little bit more. So feel free to check out our Airway Health Solutions YouTube channel, and perhaps you want to share that with your colleagues and patients as well. Dr. Zaghi couldn't be on this call this evening, but he said we could share his master class also. I think together we are stronger, and the more knowledge you have, the more competence and confidence you'll have, and then we can help more patients breathe, sleep, and thrive. I'm a huge proponent and such a proud partner of the Children's Airway First Foundation. Please take a look at their website. They have a wealth of information, and I'm sure they're going to have more on tongue tie releases as well for the support you need. So please visit and maybe consider a small donation. We do have a public Facebook group that you can be part of. We'd love for you to join, and we'll keep you updated on new information and just chat about all things airway. So please feel free to join that. If you're looking for people to refer to, you may want to look at our airway dentist locator. I'm not saying they're tongue tie releasers or providers, but they maybe can help you find those areas because they work with them if they don't do the procedures themselves. So consider checking out our locator. Here are some upcoming events. The Airway Palooza. I just want to give a shout out to this one. A lot of our panelists are on and attending. We do have a $200 code, so hopefully it's not too late to join. The room rates are great. Actually, for the Ritz-Carlton, it's $359, and those are selling out fast. So if you want to join us, don't wait. I tend to wait to the last minute for courses. Go ahead and sign up today. We would love to see you there. I want to give a shout out for Dr. Gerald Simmons' sleep conference. It's a sleep symposium. This is his 20th year. So we'll give you this follow-up information, but I know everyone likes to know what's up and coming, and I'm happy to share that with you. Save the date for Collaboration Cure, September 12th through the 14th in Reno, Nevada. Hopefully the Pulmonauts will be playing there again. We really had a great time at the last event. And here are just some free events I want to share with you. I'm thrilled to have Sharon Moore join me. That'll be soon. I can't believe February is around the corner. February 7th, we're going to have Sharon Moore, and there'll be free CEU credit for that as well. And then Dr. Ben Moralia will be providing a free conversation on the role of the dental team. We're actually going to partner with Children's Airway First Foundation on this, so you can invite your parents, patients. It will be patient and parent friendly, so everyone can learn kind of the warning signs, so we can actually prevent problems from happening. And then if you are part of our alumni, we do offer a town hall quarterly for your questions, kind of like a roundhouse discussion. We would love for you to join us for our alumni. So just some housekeeping items. You will receive a follow-up email. Please look at it carefully. We'll be giving you a lot of information. You'll get that with the recording by January 28th. We have a lot of people on this call today, so please don't email us about when you will get your CE certificate. If you've attended the full 2.5 hours, we will mail it to you automatically to the email that you registered with. So if you need a different email, feel free to contact us at info@airwayhealthsolutions, there's a typo in there, .com. But please add us to your contacts so we don't end up in your spam folder. We must get hundreds of emails saying, I never got my CE, and it's in the spam. So please help us with that. We'll be very, very grateful. I wanted to give a shout out because we have a new course with our first medical faculty member, Dr. David McCarty, and that's coming around the corner. So I thought I'd just give it a quick shout out and highlight that this is a course for everybody, every healthcare practitioner. You need to learn about sleep apnea and how to have that empathy lens so you can help your patients and actually maybe help your own family members or perhaps yourself navigate and unpack the complexities of sleep apnea. So he's a charismatic speaker and he puts humor and really makes it more of an adventure while you're learning. You don't even realize you're learning. You're kind of having too much fun. So please consider that, and that'll be on the follow-up email as well. So I would like to just do our raffle, and I'm sorry we were a little bit over. We did have some technical difficulties. And spin and see who is our raffle winner for tonight's Airway Palooza virtual ticket. I'm going to stop my share, I think. There we go.
And I tried to answer as many questions as I could get to, so check the Q&A, see if your question was answered.
Yeah, and also we can give a report of those questions, and that was very helpful. So thank you for doing that. So while the wheel spins, let's see. Alexandra Strachan is the winner this evening. So welcome. You're going to get a wealth of information from many speakers for the Airway Palooza. Day 1 is pediatrics. Day 2 is adult dentition. So we're thrilled about that. So thank you, everyone. I cannot thank the panelists, the speakers enough for tonight, for sharing your time, wisdom. We probably could talk for a day, but you know, we have to start somewhere. I love the enthusiasm. I love that we had 1,200 people sign up for this course. So there is interest, there is momentum, and it's because of people like doctors like you who take the time to really care about their patients and learn, and we're stronger together. So as long as you keep coming here, we'll keep showing up. Thank you, everyone. It was a wonderful
question, Lauren.
Yes, please.
People on the panel, I don't remember registering. Will we automatically get our CE credits too?
Yes, absolutely.
Okay.
Just don't email me about it. I'll send it to you.
And Richard, you got to grow a beard like the rest of us, okay?
Right? I did no shave November one time. It was fun. It was real scratchy though.
Yeah, and if anyone wants a closing remark here, I was just being mindful of the time. Everyone has their CE and all. Please feel panelists. Do you want to come off a mic and say anything closing? Because everyone really loves to hear what you have to say.
Oh, this is so great. It's so good to be among friends. Thank you, everyone. It was so nice to see you guys. And yeah, I'm excited about the future. It's a bright future. But like Brett said, we need more research. So if you're interested in doing research, please, with data, that's critical.
Publish, publish, publish. I hear David McCarty in my ear.
Exactly. Empowered.
Kevin, you're on mute, Kevin. I see your mouth moving, but you're on mute. Wait, you're still on mute. You still
I watched.
There we go. Go ahead.
Probably so. Lauren, you did such a bang up job organizing this, and we're all grateful to you.
Yeah,
So,
thank you.
Absolutely. Thank you, Lauren.
Really my pleasure. So you keep showing up, we'll keep showing up, and together we're stronger. Thanks, everyone. Dr.
Great
Siegel,
job, guys.
we have your
Thank you.
back, and everyone.
Next one will be in Greek.
All right.
We'll see
Thanks,
you guys all at
everyone.
Palooza.
And we'll see you at Airway Palooza. That's right. That's right. Take care, everyone. Thank you so much.
Good night,
Thank you,
guys.
everyone. That was awesome. Thank you.